Welcome, everybody. It's so great to have so many of you here in the room to join us for the Healthcare Innovation Conference, which is organized by AmCham, our healthcare committee, together with the European Commission, who has helped us in this. It's great to have you in the room. We have people listening online. We'll be recording this event, so we are all set. Hope you are too. We will have 3 keynote speakers in the now up until 11 o'clock. Then we will have a break for half an hour, and then we will have from 12 to 2 speakers plus a panel discussion, all innovation and access to innovation in Estonia. Let us see where our day brings us. We are really happy that this is an annual event. We are really happy that we have been able always to invite the minister to our event. So thank you, Minister, for coming. And without any further ado, I will introduce our first speaker, who is Peep Peterson, Minister for Health in Estonia. Please.
Thank you very much. Dear AmCham, actually, this is not my first time with you, because I remember when we had the discussion between EU and US about the free trade agreement. We had a nice trip to Stockholm. I was back in trade unions back in this time, and we discussed how open our societies, both in Sweden and then in Estonia, should be. And we understood that being open for trade, being open for cultural exchange, it's so important, and so we can't close ourselves, and should be also open for more trade and more cooperation. And actually, it leads also to this moment here, the innovation. It is never, about being closed. It's never about being like, having very strong borders. It's all about, communicating, all about the links over the ocean, over the world, basically. And I think this is something which has helped Estonia very much, is just to be really open-minded, being really active in these human connections, really going out and reaching to people all over the globe. And then this has helped a lot. And so my duty as a minister is also to keep it open, really open for all kind of ideas, all kind of innovations, for future. Because, what is the innovation in healthcare? It is basically how to. It's not, the innovation as such is not something special. It's not just the innovation as such. It is about the goal we are actually trying to reach. The goal in Estonia we have agreed is to first, of course, we are seeking for a longer life, but we are also seeking for more quality in life. So when our health insurance fund is talking its annual goals, the most important goal basically is how long we are staying healthy. This is most important, because we know that, of course, how long we live, this is dependent on so many factors, and then basically it's getting better anyway. The most important thing is how long the people are feeling themselves really active, how long they can say that they are basically healthy. Maybe they have some diseases, but when we can compensate these diseases, long-term disease, basically when they feel that they're comfortable with their sickness, then they can also answer it. Yes, but I can live with that. And this is healthy living, and this is so important. In the same time, the whole picture is also that we have been very efficient, providing so much care and very high quality care for very little money. basically in European Union. I'm not sure that there are some other countries which are actually spending less and getting so much for this money. Spending like 6%. Lately, I think it's 7 or 8% of GDP investing into healthcare and getting back European level, which is the highest level in world. The top level services for this amount of money. When we go back to US, I'm not sure that the quality and price, the connection is the same. But being so efficient, it means that you are seeking for more, and it can't come from the usual stuff that the doctor is doing more, just like physically. It can't. The effectiveness can't come from the fact that somebody is working more. It has to be more clever, and then this is where actually we come to the moment that we need to discover the illnesses before. We need to detect the problems before. We need to make sure that people are maybe not getting the illnesses, for example, cancer. Then when they get the cancer, we need to detect it as early as possible. It's much cheaper or much more effective to intervene when you are detecting it very early. And then when the person actually needs some more care, we need to be sure that the care is complex. That putting in a lot of money healing the person, we need to take care that the person is staying healthy after the procedure. Which means that we need to link the social kind of aid to that. Just making sure that the whole process is really like complex and let's say the quality of life after the illness and the cure. It is actually going to be like a really full complex. I'm not very clear in what I'm talking, but you understand. You have to look at the whole procedure and innovate in every step. Talking about Estonia and innovation, when we look at the e-tax system, the tax department, the e-tax department, what it discovered is that it doesn't help to do some IT stuff only. It is all about taking the help of IT, but changing also the procedure, the business procedure, and then basically it is the same. It has to be the same also in medical. That just thinking about new things, you have to change also the protocol, how you do the things. When it's just like a mechanical thing, that we have a kind of toy again, and then another toy, and then one more toy, it doesn't help. We have to be creative when we are talking about the toys. It has to change something in the big picture and the big procedure. So when we are innovating, we need to understand the business, what is the word, flow, the ideology of what we are doing, and just put your innovation into it, and maybe also change the kind of flow. That's why I'm really happy about some kind of things what we are doing in Estonia. First, of course, the e-health, which is not perfect because putting more applications on a Christmas tree, it might happen that the Christmas tree itself is kind of not standing so strong anymore because there are so many applications, and now we are taking care that the tree itself is going to be stronger, so we can put more on it. This is one good example, but the other one. Actually, what we are doing is basically we have 210,000, somebody can correct me, gene pools stored somewhere in Tartu. I've been there. Now the question is, how much are we taking out of it? What are the really clinical kind of results what the people are getting out of it? We know that 3,000 people have got warnings about high risk of cancer. But I'm not sure how they really answer it. What is the procedure after that? Is it something which is actually continuous help? I understood, I've heard from some clinics that actually it has much to do that, this information what we have gathered and what we are going to gather about the people is going to help the patients really to survive cancer risk, maybe some cardiovascular risks or some other risks. So this is one thing that we have to work together. That having this data, that all the research out of it is actually leading to the real movement. That the doctors are really implementing something, changing the method how they are dealing with patients, and this long story we have to fulfill in the procedure of research, every step, so that we start from the very basic of the genetics, and we end up with a real procedure which is in the list of Tervisekassa, in the list of Tervisekassa as with the price tag on it. So. And this is something where we actually can't be alone again, Estonia alone, but we have to organize, and then invite others in the European Union, also with the US, and open up this data for more innovation. And this is something I'm planning to do during my stay in office, so that when I'm leaving, I know that the truck is there and then the thing is going. And this is actually going to create so much innovation, the genes and everything out of it. This is my plan. But this is only one direction. The directions can be so many. I know that in Estonia there's also research about new medicines. There has been research about vaccines. There are so many lines. We know that the IT is one, the genes are the second, and then maybe the vaccines and the medicines, this is the third one, but there can be so much more. Our Tervisekassa, the health fund, it has a small fund under it, which is only for innovation. But this, I understand that this is the last mile innovation. So something is really ready to bring into the clinics, but there's something little missing. And this is what we are covering from there. This is not the very old one. I think it's like 4 or 5 years old. So basically, when you are innovating something and you are very close to real practical solution, please come to our health fund and you get the rest of it from there. But just ensuring that the flow things are coming there. It needs some cooperation on European level, being very open, attracting innovators to come to Estonia to create connections to our universities, to our practitioners, and just do it. So it is a wonderful place to innovate. We are very open to it, and we can bring it to the hospitals, to clinics. And we can see the results. So this is basically my story here. Thank you very much.
Thank you so much. Do we have microphones as well? Can we have a quick question? Okay. Daria, maybe you can help me with the mic. Do you have a question from the floor? It's an opportunity of a lifetime. Huh? Here, here, please.
Thank you so much for this presentation. So I'm Liudvika Sterkienė from Amgen from Lithuania, also responsible on the Baltic level. You touched throughout your presentation very important aspects. So first you mentioned that it's very important in case of oncology to detect the disease early, then to have treatment, whatever is needed at the needed stages. You also mentioned importance of e-health for collecting the data. So I was wondering, and I know that Tervekassa, now I'm also using this new term, has done a great pilot project regarding stroke patient pathway mapping. So maybe this is not the right question to you, but maybe Mr. Alanya can answer. So are you planning to expand? Because I think this is a very successful project. And just to understand that for such patients, for example, taking stroke, it's very important at which stage they are to move from one, because there is multidisciplinary care involved. So let's say a hospital level, then moving to rehabilitation, then to GP care, to make sure that all the pathway is smooth. So are you planning to pilot, let's say, more projects? What would be the areas, and how do you plan to utilize this data that you would be collecting? Because you have really great e-health system in place. So maybe could you elaborate on that?
I will try to answer. We are actually very keen to look into these pilots and the results, and we are very keen to bring it to like a normal status of business. I'm not sure. I think Rain can say how far we are with that, but it's absolutely why we are doing it. We want to offer it to everyone, because otherwise we are just losing money, putting in, I don't know how many thousands of euros, maybe 10,000, maybe 20,000 euros, making a perfect surgery. And after 2 years' time, the patient is kind of either dead or laying in a bed. It doesn't help just putting money into surgery. It has to be complex. And then if it's not that far, we are going to meet on a strategy meeting quite soon. We are going to talk about it further.
Thank you so much. So thank you very much for joining us. And there is a lot of questions. Maybe a quick one, because we need to move on.
Hello, I'm Christina. I'm from Tartu University Hospital, head of the Hematology Oncology Clinic. So I just wanted to give a comment about this genes and clinics. So just to know that in Europe now we have this cancer mission, many projects, and we have a resolution from the European Parliament as well from the February 25th, I think. So it is very important today for the innovation in the field of medicine that we can transfer the data from scientific research to clinic. So I'm and vice versa. So I'm very, very, very happy that we are dealing with it. Thank you.
Yeah, and I wanted to comment also on this. Last time we gathered in Prague with the ministers of European Union, health ministers of European Union. The cancer was the topic. And my call to my colleagues was that let's put the efforts together and do it commonly. Let's put the universities together, just cover the whole journey up to the clinical, but then also the data, the data room. By the way, the commissioner is coming to Estonia quite soon, and this is one, and then the cancer is her favorite topic. So we are also bringing in the gene and just showing how much we need to do all together and put efforts into it.
Well, thank you so much, Minister. We should have reserved so much more time for you. We hope you will be Minister for Health next year. Absolutely, also. Yes. So we will make a longer slot then. Yeah. So thank you very much.
Thank you. Thank you.
Okay, and now we can go forward, and European Parliament was mentioned. So we will have an online speaker, member of the European Parliament, Juozas Olekas. So I hope you can hear us. and we can.
Yes, I'm there. See you.
You can
I'm
see
sorry
me.
for delay.
Very good. No worries about the delay. Can we see the picture also? Just a
Yes,
moment. We are fixing it on the screen. Okay, it is here. Very good. So, Juozas Olekas, please, we very much welcome your thoughts on healthcare innovation.
thank you very much, dear colleagues, dear friends. First of all, I would like to thank the American Chamber of Commerce for inviting me to speak today on this very important topic. As former Minister of Lithuania of Health and surgeon, I can say that innovation in healthcare is essential if we want to not only treat the diseases effectively, avoid more pandemic, and solve current health problems, but also prevent diseases and make sure that we live in more healthy and happy society. As a member of European Parliament, I have spent considerable time and efforts on EU roles in securing the best available healthcare procedures and treatment, as well as necessary EU-level policies for ensuring the health for our union citizens. Our citizens have spoken very clear in the course of a conference for the future of Europe. They supported the European Health Union and common European approach to healthcare. This position should be taken very seriously, especially nowadays when we are coming out of a global pandemic and looking at the future challenges in healthcare sector. Europe and the World War just went through the potential challenges caused by COVID-19 pandemic. It caused a health crisis, economical crisis, health crisis, and it presents that essential challenges to the European project, where we're doing enough to protect the health of our citizens, or would our efforts have been even better if the European Union powers in the area of public health policy had been stronger? The subsidiarity that is currently in place limits us from being able to help people. Individually, not every member state can provide the same quality service in the field of healthcare. Tomorrow we will be raising awareness of cardiovascular diseases through the World Heart Day. It is particularly distressing for me that the prevalence of cardiovascular diseases is significantly higher in our part of Europe, eastern part, and central Europe, than in the Western, Northern, or Southern European countries. There are significant differences in the number of cardiologists, the availability of the vital medical equipment, and intervention performed in the EU countries. These large disparities in access of good cardiovascular care between the EU countries should be of great concern to the EU and the national policy makers. As a European Union, we can no longer tolerate these kinds of drastic inequities in our society. Other examples of the negative effects of this lack of cooperation could be seen in the rare diseases. Rare diseases sometimes take years to be diagnosed, and once they are discovered, doctors find themselves without the adequate expertise to cure this disease. The time has come for the better union, where EU citizens in need can receive such assistance at the EU level, regardless of their nationality, and the Europeans agree with us. We say that it is time to make healthcare equal for all in all European Union. From the very beginning, the European project was about saving lives. When the French Foreign Minister Robert Schuman delivered this declaration in 1950, he focused on the importance of eliminating war in Europe and stressed the importance of pooling European coal and steel production. The emphasis on heavy industry and later on agriculture became the backbone of European integration. goals such as saving lives, promoting good health, and long life unfortunately vanished from the radar of the main European policy debate. It is a very limited reflection on health matters in the European treaties, and this contradicts the main trends of development in nowadays modern society. Today, for example, in the Eurozone, the health employs more labor than agriculture, fisheries, mining, and heavy metal industry combined. Medical technologies have become so complicated that smaller member states do not have the capacity to manage rare and complex diseases and rare cancer. Unfortunately, European Union is not fully prepared for the challenge of protecting our citizens' health. There are weaknesses like poor coordination of activities among the member states, limited reserves of essential supplies, shortage of healthcare workers and medical supply. It is clear that our citizens are asking the European Union to do more, but the hands of the European institutions are tied. The Union can only operate on the basis of powers allocated by the treaties. According, the European Commission has no legal basis to strengthen its own resources to address public health crisis. I fully believe that more can and must be done at the European level. Health is essential when it comes to the fair and sustainable development of our society. Health is the greatest value we have, contributing to the well-being of individuals and paving the way for the prosperous societies. The role of health policy in the European treaties should be reconsidered in order to tackle the asymmetry between the strong regulatory and weak implementing powers of the EU in this area. We must go toward the objectives of more proactive public health, more solidarity in Europe, more cooperation to build resilient healthcare and care system. Public health activities should be undertaken not only at national but also at the EU level. The European Commission should not only regulate, coordinate, supplement, and cooperate with member states, but it also should have its own resources and competence in the area of public health and treaty-based right to react as quick as possible in dealing with the certain public health emergencies in coordination with the member states. The EU should share responsibilities in care and cure in the areas of rare cancer, rare diseases, by preserving subsidiarity as a core principle. All of this should not be only focused on healing and managing existing conditions, but also on prevention and early diagnosis. There are many studies which highlight that providing better treatment as early as possible contribute not only to the better health and individual patient, but the society as a whole. The healthier the population, the less burden would fall on the public health system. Better public health as well not only reduce the burden of public resources, but in turn contributes to the growing of the GDP and the well-being of the people. Healthy people can care on their lives, work and live their lives fully, which the benefits of the whole society. We are living in the age of innovation, new technologies, and new solutions to our problems. The perspective of our future will be so challenging, but also very promising. With the new advancements in the technology, we are waiting for the new techniques in the fields of drug development, medicines, and therapies. New technologies in medicine help us achieve a more effective target treatments that help patients recover fast. We have scientists and entrepreneurs working on this, including in my native Lithuania. The biotechnology sector is rapidly growing. Lithuania has more than 20 companies working in the fields of new technologies, development infrastructure, become a life science leader of Europe with 7 universities and 7 colleagues with biotechnology programs, 16 research centers and 5 centers of business value. Over 8,300 qualified researchers and investments of more than 400 million euros. This research and development is also an area where the more common EU approach for health and more funding for this research would be very helpful. It is clear that we need more health innovation in the EU. We are facing major health and economical challenges and social transformation that have been accelerated by COVID-19 pandemic. The health and the well-being of European citizens require innovation, long-term vision, and increased profile of health among the EU policies. Thank you.
Thank you, thank you. Thank you so much. We do have time for questions, so are there any questions from the audience? Before you get heated up, I will have a question of my own. I would like to thank you so much for your foresight and for your leadership in those issues. It's really great to hear that EU is also stepping forward on those questions. Do you think that it is possible to keep health on the EU agenda, given the difficult situation with kind of international relations? Can it be still health on the agenda of EU?
Yes, thank you for the question. Indeed, we here in the European Parliament, for example, we didn't have the committee on the health. We just have the small subgroup in the Environment Committee. But anyway, the pandemic of COVID-19 helped us a lot. That this attention to the health was so huge. And now we established the committee for lesson learned of the COVID, the special committee for investigate, evaluate what we can do differently. And I hope that different NGOs activities and different cooperation between the European Parliament members and societies and patient groups and physician groups, I said this created a huge input on that. And as I said, in the conference of Future of Europe, it was a lot suggestion from the different societies that we need to have more attention on European level. It's a little bit difficult because it's usually, as I said, related with the treaties, and it's not too easy to change the treaties. And we're still discussing here in the European Parliament that we need to create a new convent and discuss about the vision of European Union future and maybe put more attention on the health issue also.
So much for this. All good wishes go from us to you. So thank you. Okay.
Thank you.
And now we have Rain Laane, our Health Insurance Fund chairman, to hear about more concrete Estonian situation and the thoughts. And Rain will be also in the panel, so if we are not able to take questions now, we will be able to have those later on, so we have the opportunity.
Good morning. It's honor and pleasure to be here, and I think many of you knows that there is a special place in my heart for American Chamber of Commerce. Magically, I think I should say abracadabra, and the slides are there. So there are tons of things to tell, but 20 minutes I can have, and then I will run and be back in the panel at 1 o'clock. There is a saying that it's a pity to waste a crisis. Unfortunately, those 3 crises where we are right now, or where we have been last, I would say, 3 years, are not nice at all. First one is, which everyone knows and maybe have felt. Our member of EU Parliament said we need to learn out of that one. And we have done also many learnings, things which could have done better. You always need to place you in the moment, back in the moment, 1 year ago, 2 years ago, 3 years ago, to understand why we made such a decisions, why it looked a little bit hectic when we talk about vaccination, communication, people awareness, etc. And unfortunately, I think it's pretty much the same in all Baltics, that two-thirds of people are vaccinated and 1/3 thinks differently about that one. When we look Nordic, then they are ahead of many things. But I'm pretty sure one day we will catch it, and the day comes sooner than later. Another crisis, this picture I took my apartment house roof, because several years ago we put these solar panels. And now it feels that we are enjoying that one, while others are complaining about high prices. Sometimes Estonian Energy pays to us. We could say we were lucky, but maybe that was a clear decision. This is why I put it here, because today we have challenges in many of health services providers how to pay the electrical and gas bills. And we are trying to help. We are really trying to help, because as the almost sole payer in Estonia, there is nowhere else they could get it. Yesterday, I will put this picture. Yesterday, there was a big defense or our national security conference, where our Prime Minister, Minister of Defense, said very clearly that resources, when I'm talking finances, when I talk euros, is always short. And when you look the state budget, pretty big number went to the our own security part, Ministry of Defense. And I think it's right. I always want to have more money in the health sector, but in the crisis where we are right now, and when we look our sisters and brothers in Ukraine, then I am happy as an Estonian citizen that we are helping. We are helping them, and we are helping us. That I touched a little bit, and the state budget is not locked at the moment, but it will be basically locked, I guess, tomorrow. So, Minister, and we still have little room today to get the better result than it is right now, to be honest. And when I go back with the COVID slide, when COVID started, we saw, unfortunately, that when European countries are closing their borders in the beginning of COVID, when everybody did it, that's not the way as we should do. But today is an health innovation conference, and these slides were just setting the scene and warm up. What we are doing in Health Insurance Fund. Maybe you have seen this picture earlier, but we have our strategic plan, which luckily our council approved this year in May, I guess. And it consists of four main pillars. Three of them are pretty solid. We know what to do, how to do, and laser, yes, green laser. And that part is under construction. That's ourselves, but I will touch it and I will reach there. So we have clearly defined three journeys. The health journey, the treatment journey to help people who really need medical help. And the third one is digital journey, because I would say majority, if not all, the companies, institutions, organizations, they rely nowadays on information technology. Without that one, there is one big crisis all the time. But health journey, and I will stand, I guess, this side. And this is really journey. I'm a very strong believer of prevention, disease prevention, and health promotion. Because on one hand, that's the cheapest way to keep our healthy lived year climbing higher and higher. And on the other hand, I think we feel better when we don't need to visit all the health services providing institutions. And we start with children, the special programs, and how to make sure that every children will raise up and stay healthy and have right understanding how to keep their health in a good balance. Because I would say 70 to 80% of the diseases are somehow related with our lifestyle. And that is what we can change. We can change how much we consume, how many kilometers we move. And today is beautiful September. There is a campaign in September that we don't drink alcohol. This year I decided to participate, and today is 28th already, I guess. 28 days we can do. And then when we continue with, start with children and continue with the adult people, then you can change today. Even today you can change. It's not late to make the mindset change and start with small steps. There are many special programs which I can't cover right now. Maybe a few questions I can answer in the panel. But when we go to the treatment journey part, then thank you for the question about the pathway or patient journey, because that's one of the main pillars of ideas. Beside value-based healthcare, where we would like to move, value-based healthcare means with one sentence that we will measure the result, and based on the result there will be the financing. That's a journey. We can't switch it over the night. And beside the stroke journey, where yes, there are 4,000 strokes every year, and our aim is to get the patient or the human being who suffered on stroke back to the normal life as quickly as possible. This has been pilot now for 2 years, and I think pretty soon it's ready to go to our so-called price list. There are several other projects which are on the pilot stage or will go in the pilot stage. I can mention endoprothesis, knee and hip replacement journey, because that's also not one surgery or operation, because it requires the rehabilitation and all the other clinical psychological stuff there. Then mental health, and that picture also somehow indicates mental health is pretty high in our agenda. When we talk about depression and the journey how to get out of the depression and be a better citizen and contribute to the society more and be happy. Then we are looking, when we are looking oncology part, colorectal cancer, there are some pilots which we are doing together with Estonian hospitals. And there is very clear goal, as Minister Peep Peterson said, yes, we are not doing just pilots to test something. The pilot is the beginning of the journey, and it should land after 2-3 years in our price list when everybody are ready. In this health sector, for me, I'm a pretty impatient person. I would love to get results way, way, way quicker than it is. There are tons of challenges. I hate the word problem. I call them challenges, and challenges are to overcome them. One of things is data exchange, and I think that's everywhere. I love Data Protection Agency in Estonia and in some other countries. I understand they do their job, but when I was in Finland a few weeks ago, and when I learned that Helsinki University Hospital, they are fully in the cloud. They keep their data in Finland and in some other EU country as a backup if something happens. And I asked question, how did you do that? How did you manage with your DPA, Data Protection Agency? And I got a nice answer. They are also people. They are reasonable people. We talked to them. So we try to do the same here. Smoothly, we reached to the digital journey, and the more deeper you dig in our systems, and yes, we do have lovely e-health system in Estonia, tervishoiu infosüsteem, TIS. 2007, or 2008, when it was launched, it was really second to none system compared to what was available at that time in the world. Today, when we look back, sorry when I'm a little bit too harsh, it's a bunch of documents. It's valuable data, but unfortunately we are not able to search quickly. And when you are a doctor, you spend 15 minutes looking at the computer, not the patient who came to see you. How can we do it that you as a doctor or nurse, you don't spend more than 3 minutes looking at the computer? Look the patient. And if you can do quicker, then you can advise several patients at a time. Again, the example from Finland, this is a private insurance. What they are doing, their doctors are chatting with the patients. And the younger generation, when we look, they do not like to call. They don't know what is the calling when you dial the really number with this. They love to chat. And you can imagine that there is a doctor who has, and this is a real story, there is a doctor who has 6 chat windows. And when you ask question, people think what to answer. How do you feel? Great, super great, not so great. And this is like a Garry Kasparov plays chess, simultaneous chess. One hand, it raises efficiency. Doctors earn more money, of course. But on the other hand, when you look at it from the human side, we can get the answers quicker. Because if there is a 20-minute slot, 3 patients per hour, now you can multiply it by 6. This doesn't fit to everyone. But definitely there are some people who enjoy that one. If we talk the same, I will go back. If we talk the mental health part, then this is one-on-one conversation. This is one area where the video appointments are still very valid and working very well, because psychiatrist or the shrink in US, they can work in their home office, and the patient can be also in their home office, not going to the hospital, because some people do not want to go to the hospital which is providing mental health services. There are tons of things we would like to automate, because even in our house, I have to admit, there are still some papers. Mainly, we are receiving papers from the abroad, but I can say that some countries, looking Finland, looking some other countries, we have managed to exchange data and documents fully automatically. Last but not least, our own organization. Our aim is, because there are many people in Tervisekassa who have came from the private sector now. This is a little bit different experience, and we would like to measure what we are doing. We would like to measure the value which we are providing. And to do that one, we are right now in the process of turning our organization to the service-based organization, which means that no more silos anymore, but there is the customer, we call it customer, the human being or the patient, who wants some service. And it goes through our silos, because we still have digital, digi part, health part, insurance part, and all supporting functions, legal, HR, communication, etc. And I hope that you can give us pretty soon some feedback next year. How are we doing? Have you seen any change? And that's one of the last pictures, which background is cooperation. When you look these lovely puppies, they might look a little bit sad in that picture, but they are playing together, they are eating together, they are enjoying time together, and that is the cooperation part. That is where our organization is based, because we are all human beings. And what I learned in my 20 years business career, that people buy from people. If that is okay, then I will take the questions at 1 o'clock in the panel. Yes. Thank you very, very much.
This is just perfect. Thank you very much for introduction. And we will see you back quite soon. And now we will have a break of half an hour. And after that, we will have excellent speakers and the panel discussion. So please don't even think about going away from here. So please be back in half an hour.
Walk again. I'm floating in a beam of light with you, a beam of light with you. Reached out a hand to touch your face. You're slowly disappearing from my view, disappearing from my view. And I ran so far away. I just I ran all night and day. And I ran so far away. I just I ran all night and day. I couldn't get away.
I know what I came to do, that ain't no gonna change. So go ahead and talk your talk, cause I won't take the bait. I'm over here doing what I like, I'm over here working day and night. And if my reel ain't reeling up, I'm sorry for you, babe. Let's find a light inside our universe now, where ain't nobody keep on holding us down. Just come and get it, let them say what they say, cause I'm about to put them all away. Focus on me, focus on me. Focus on me, focus on me. I can tell you're curious, it's written on your lips. Ain't no need to hold it back, go ahead and talk your shit. I know you're hoping that I'll react, I know you're hoping I'm looking back. But if my reel ain't real enough, then I don't know what it is. Let's find a light inside our universe now, where ain't nobody keep on holding us down. Just come and get it, let them say what they say, cause I'm about to put them all away. Focus on me, focus on me. Focus on me, focus on me. 1, 2, 3, 4. Let's find a light inside our universe now, where ain't nobody keep on holding us down. Just come and get it, let them say what they say, cause I'm about to put them all away. Focus on me, focus on me. Focus on me, focus on me. Focus on me, focus on me.
Goodbye, my love. The tide waits for me. Who knows when we shall meet again? If ever. But time keeps flowing like a river to the sea, to the sea, till it's gone forever, gone forever, gone forevermore. Goodbye, my friend. Maybe for forever. Goodbye, my friend. The stars wait for me. Who knows when we shall meet again? If ever. But time keeps flowing like a river to the sea, to the sea, till it's gone forever, gone forever, gone forevermore. I don't know where I'm going, but I sure know where I've been. Hanging on promises and songs of yesterday, and I've made up my mind. I ain't wasting no more time. Here I go again. Though I keep searching for an answer, I never seem to find what I'm looking for. Although I pray, give me strength to carry on, 'cause I know what it means to walk along the lonely street of dreams. Here I go again on my own, going down the only road I've ever known. Like a drifter, I was learned to walk alone, and I've made up my mind. And wasting no more time. Here I go again. Just another in need of rescue, waiting on love's sweet charity. And I'm gonna hold on for the rest of my days, 'cause I know what it means to walk along the lonely street of dreams. Here I go again on my own, going down the only road I've ever known. Like a drifter, I was born to walk alone, and I made up my mind. tell. Sometimes it gets so hard to hide it well. I was not ready for the fall. Too blind to see the writing on the wall. A man can tell 1,000 lies. I've learned my lesson well. Hope will live to tell the secret I have learned till then. It'll burn inside of me. I know where beauty lives. I've seen it once, I know the warmth she gives. The light that you can never see. It shines inside, you can't take that from me. A man can tell 1,000 lies. I've learned my lesson well. Hope will live to tell the secret I have learned till then. It'll burn inside of me. The truth is never far behind. You kept it hidden well. If I live to tell the secret I knew, then will I have the chance again. For run away, I'd never have the strength to go very far. How would they hear the beating of my heart? Will it grow cold, the secret that I hide? Will I grow old? How will they hear? When will they learn? How will they know? Man can tell 1,000 lies. I've learned my lesson well. Hope will live to tell the secret I have learned till then. It'll burn inside of me.
I've been trying to call. I've been on my own for long enough. Maybe you can show me how to love. Maybe I'm going through withdrawals, and you don't even have to do too much. You can turn me on with just a touch, baby. I look around, since it is cold and empty, no one's around to judge me. I can see clearly when you're gone, you're gone, you're gone. And I say
I'm blinded by the lights. No, I can't sleep until I feel your touch. And I say, oh,
'cause I can see the sun light up the sky. So I hit the road in overdrive, baby. Oh, the city's cold and empty, and no one's around to judge me. And I can see clearly when you're gone, gone, gone. I say you. I'm just walking by to let you know I can never say it on the phone. We'll never let you go. A 1, 2, 3. Bum, bum, ba-da-bum, boom, ba-da-bum, bum, ba-da-bum, boom, ba-da-bum, ba-da-bum, bum, ba-da-bum, bum. I said, I'm drowning in the night. Oh, when I'm like this, you're the one I trust. I heard you crying loud all the way across town, 'cause you've been searching for that someone, and it's me out on the prowl. So sit around feeling sorry for yourself. Well, don't get lonely now, and dry your whining eyes. I'm just roaming for the moment, sleaze in my backyard, so don't get so uptight. You've been thinking about ditching me. No time to search the world around, 'cause you know where I'll be found when I come around. When I come around. Well, I've heard it all before, so don't knock down on my door, 'cause I'm a loser and a user, so I don't need no accuser to try and slag me down, because I know you're right. So go do what you like. Make sure you do it wise. You may find out that your self-doubt means nothing was ever there. You can't go forcing something if it's just not right. No time to search the world around, 'cause you know where I'll be found when I come around. When I come around. When I come around. When I come around. to a stranger. You know in the end I'll always be there. But when you're in doubt and when you're in danger, just take a good look around and I will be there. Oh yes I will.
I'm sorry, but I'm just thinking of the right words to say. I know they don't sound the way I planned them to be, but if you wait around a while, I'll make you fall for me. I promise you I will.
When your day is through and so is your temper, you know what to do. I'm gonna always be there. Sometimes if I shout, it's not what's intended. These words just came out with no cross to bear.
I'm sorry, but I'm just thinking of the right words to say. I know they don't sound the way I planned them to be, and if I had to rock the world, I'd make you fall for me. I promise you. I gotta tell you, I promise you I will. Come to decide that the things that I tried were in my life just to get high on. When I sit alone, come get a little known, but I need more than myself this time. Step from the road to the sea to the sky, and I do believe that we rely on. When I lay it on, come get to play it on all my life to sacrifice. Hey, oh, listen what I say, oh, I got joy, oh, listen what I say, oh. When will I know that I really can't go to the well once more time to decide on? When it's killing me, when will I really see all that I need to look inside? Come to believe that I better not leave before I get my chance to ride. When it's killing me, what do I really need? All that I need to look inside. Hey, oh, listen what I say, oh, come back and hey, oh, look at what I say, oh. The more I see, the less I know, the more I like to let it go, oh, hey, oh. Deep beneath the cover of another perfect wonder, where it's so white as snow. Bridally divided, one side and then there's nowhere to go. In between the cover of another perfect wonder, and it's so white as snow. Running through the field where all the tracks will be concealed, and there's nowhere to go.
Okay. Okay, we are back in the room, looks like it. So welcome back, and be ready for now deep dive into expert presentations and best practices from abroad. So we are going into details now. And first up, we will have an online presentation Do you have Professor Panos Kanavos online? Let's see whether we have the professor online. Professor Panos Kanavos is Associate Professor in International Health Policy in Department of Health Policy. He is the Program Director at Medical Technologies, Deputy Director in LSE Health, and as far as I know, all of this is London School of Economics, so lots of titles. Do we have you with us, Panos Kanavos, Professor?
Good morning. Yes, you do. I can hear you loud and clear.
Okay,
I don't know if you
great.
can see me.
Great. So we are very much looking forward to your presentation on the UK health technology assessment system. What are the recent and upcoming changes, and what are the lessons learned? So we are all ears.
Great. Good morning, and thank you for the kind invitation. If something is of an issue with regards to the audio, please let me know. But I will carry on, assuming that everything is okay. I've opted to talk to you a little bit more than the UK because I think HTA systems present a number of very interesting features which may be relevant for consideration in the Estonian setting, and obviously not only in the Estonian setting, but since we're talking about Estonia, yes, I think it's they present very interesting features. So what I was planning to talk about is show you some trends on HTA outcomes and showcase a little bit some of the research that we've been doing in the past 5 years as part of a European initiative which is called Impact HTA. And I think there are a number of interesting findings, but also lessons to be learned from a number of settings so that we don't have the monopoly of using NICE or SMC, which is the Scottish equivalent in the UK. I'll talk a little bit just in terms of background about the models of health technology assessment, because when we're talking about cost effectiveness, we always assume that HTA is tantamount to cost effectiveness. The fact is that we have other models of health technology assessment as well. So I think it's important to reflect on these and also the intellectual but also practical nuances. The other thing which is important is really to talk about thresholds, discounting, and time horizons, because obviously these are important considerations from your perspective. I wanted to raise the issue of and the role of social value judgments and value frameworks, and I'll finish off with that. So let's talk a little bit about HTA, key trends in HTA outcomes. So I will present 6 or 7 graphics just to show you how things are done. But first of all, a small table just to showcase that based on research that has been done from our side as part of the Impact Initiative, we do have looked at 1,415 drug indication pairs across 8 countries. And you can see the countries on the left-hand side of the slide here. Canada at federal level, France, the Quebec side of things in Canada, which makes its own decisions irrespective of the federal structure in Canada, Germany, England, Australia, Scotland, and Sweden. So these are some of the key agencies worldwide. And we've looked at, as I said, 1,415 drug indication pairs, drawing on this representative and stratified sample across all ATC categories and for a 10-year period. What seems to be the case is that the vast majority, about 87% of all drug indication pairs receive an approval, a listing, and about 13% receive a rejection. So HTA has a positive connotations altogether. But the important nuances that we need to take into consideration. And of course, you see the situation by country there. If we look at the time to HTA and stratify across type of marketing authorization, in Europe we have accelerated as well as standard marketing authorization, and accelerated through conditional marketing authorization or prime or things like that. But the fact remains that it takes longer for drugs to reach the market if they go for accelerated marketing authorization than they do by standard marketing authorization. This to many may appear to be counterintuitive, but in fact it can be explained by the fact that decision makers at HTA level wish to have complete and robust evidence, and very frequently drugs coming to market with conditional marketing authorization are really relying on incomplete or perhaps immature evidence which HTA bodies do not want to see. The other thing which is interesting from an HTA perspective is the so-called clinical restrictions. And you will see that about 40% of the sample here that I mentioned earlier on, remember it's 1,415 drug indication pairs, really have significant restrictions, either at population level, which means that HTA bodies, all the HTA bodies that I mentioned earlier, kind of restrict the label indication and reimburse for the most let's say, for the subpopulations which showcase the best effect, or they have dosing or prescribing restrictions. In other words, they give the authority to prescribe to a senior clinician, or they have both. So this is an interesting finding from an HTA standpoint. The other thing which is important here, looking at it, looking at the evidence, is the economic restrictions. And I think the green bars showcase the situation that in about 60 to 65% of the sample are subject to the so-called risk-sharing agreements. Whatever these may be, they can be outcomes-based, but in the vast majority, they are financial based, so discounting schemes or price volume agreements and so on and so forth. And remember, this is a sort of a whole sample across ATC categories. And there's some special funding as well. In other words, drugs which are subjected to HTA not found to be suitable for reimbursement, they are put into a category of their own, like the Cancer Drugs Fund here in the UK or other considerations elsewhere. This is not compassionate use, because we're talking about drugs that have actually received marketing authorization, but there are categories which are in which we earmark either for specific funding, or we subject drugs to those categories with a view to developing additional evidence. The other thing which is interesting is that about 20 or so percent across over time have received a rejection. Of all drugs that we have in the sample have received a rejection. So HTA bodies put clinical restrictions and dosing or prescribing restrictions, economic restrictions, but they're not afraid to basically reject drugs based on the clinical and or economic evidence submitted. And of course, quite a lot of these are accepted after they have been resubmitted. What is also interesting is the evidence supporting submissions other than phase 3 clinical trials. And you can see a sort of a floating trend there for about 15%, in the sense that many drugs nowadays come to market with early phase evidence, like phase 1 or phase 2. In fact, we've seen these drugs being approved even on a phase 1 basis, of course, with additional evidence later on. The other consideration which is important here is that based on an index that we have constructed showcasing quality of evidence, and you can see some of the factors that we have included here for quality of evidence, is that the majority of medicines that are approved by HTA bodies rely on average or the so-called poor quality evidence. And here we're looking at comparators used in the study design, and follow-up period. So we do have some very interesting trends on that front. And finally, I'll probably skip that, just to highlight something very important, which I will repeat later on in the presentation: the issue of social value judgments, in other words, other considerations beyond costs and effects. And here we're talking about things like severity or unmet medical need or administration advantage or innovativeness or impact on family and caring and so on. So we have the impact of a number of social value judgments, which is being considered and actually being factored in at the appraisal stage. In other words, when decisions are made about coverage decisions. So here you see three social value judgments, and it's quite telling to showcase that about 40 to 45% of all drug indication pairs considered over the period I mentioned earlier on relate, or it was mentioned that unmet medical need was an important factor. You will notice that I've put here the year of marketing authorization, and of course the sample period has been extended to 2020 in order to capture HTA evidence, which usually comes after marketing authorization, about a year, sometimes 2 years. Now, let me switch to models of HTA, and I think I will only spend 1 minute here looking at one slide, this one. As I said at the very beginning, we tend to understand HTA as clinical and cost effectiveness, yet there is the clinical and benefit assessment model, always from a comparative perspective, which is followed by countries like France and Germany, and of course the value-based pricing model, which is an extrapolation of either the clinical benefit assessment model or the clinical cost effectiveness model, in the sense that we consider factors beyond costs and effects, and that has momentous implications for coverage decisions. So I'll use that framework to discuss what is going on in cost effectiveness systems like the one we have in England or in Scotland, for example, but also in passing the clinical benefit assessment model to showcase what is happening there. So let's look at thresholds, discounting, and time horizon, because I think these are important considerations from a coverage perspective. And of course, when we're talking about thresholds, we're looking at cost effectiveness models. So some of the overarching principles that we use here is, and some of the basic assumptions, if you will, relate to three things. First of all, the economic perspective that we take into account, whether it is a broad one or a health system one. And I think systems based on this principle look at health system rather than a societal perspective. If they do, as the Swedish HTA system, take into account a societal perspective, they need to separate the health system perspective, but the addition to that, which is the societal perspective. When we're talking about the second principle, relates to cost effectiveness, in other words, the efficiency principle, and then subsequently or separately, if you will, we're looking at affordability or budget impact. And the third consideration, which is in my mind critical and links up with the issue of contextual factors which are relevant and very important in my view, is the balance between the efficiency principle, which we use in the context of cost effectiveness, and the fairness principle, which relates to equity. In other words, considering that we live, at least in Europe and other parts of the world, like Canada, for example, or Australia or Japan, we live in systems that seek to provide equitable access to healthcare services. So by subscribing to cost effectiveness only, we are leaving people behind, because cost effectiveness subscribes to what we call technical efficiency. And technical efficiency means that we make perfect use of resources. Making perfect use of resources means that we risk leaving people behind. In other words, without coverage. So I think it's an important dimension, therefore, to consider equity and fairness. And this is where contextual considerations matter. So, for example, when you're talking about end-of-life criteria, in other words, we cannot let our elderly citizens die, or people, that have left less than 2 years of life expectancy, and therefore we provide coverage, and we are, in fact, willing to pay a higher amount for that coverage. So the equity principle is very important, therefore, and this is why pure cost-effectiveness systems are transitioning into the so-called value-based assessment, which considers a whole bunch of other considerations. But obviously, we don't know by how much are these considered. So, from an English perspective, because NICE is relevant in the English context, not the UK context. We have a number of thresholds, and we have a sort of a tiered approach to thresholds. One, which is the standard at 20 to 30,000. We have another threshold of approximately 50,000 per quality-adjusted life here. For end-of-life treatment, we have a third threshold for 100 or even 200,000 pounds per quality for rare disease treatments. Then we have some budgetary issues there. So, and this is captured by. I'm going to skip Scotland for a minute because the situation is similar. I should say comparable. But we are willing to cover beyond the 20 to 30,000 pound threshold if there is sufficient evidence and if there are other conditions. So I'm going to skip this slide and in passing, I will show you some of the thresholds that we have here, showcasing on this graphic the cost per quality. So increasing on the horizontal axis and the probability of rejection on the vertical axis. And you can see the different thresholds. So we are willing to pay therefore more for different types of treatments depending on the social value judgments that we apply. And more recently, we are looking at disease severity more explicitly and unmet medical need. So the end-of-life criteria, the rarity, the unmet medical need are important decision modifiers, and we've actually selected to capture these modifiers into the acceptable threshold. If you're asking me how this 20 to 30,000 pound threshold or the 50,000 or the 100,000 pound per quality threshold have been achieved, I think we can have an intellectual conversation for the next few hours. Because, but the bottom line is that this has been picked out of thin air. So there isn't a sort of a fundamental, let's say, hardcore theoretical or conceptual framework that underpins the framework. You will notice at the bottom here of the slide something that says 13,000 pounds per quality, and that's let's say the opportunity cost. Is another threshold that the purchaser of medicines is using, or at least is purporting to use, in order to buy medicines when they negotiate with the supply side. In other words, with manufacturers. So there are many thresholds to be had in the English context. So what is appropriate? And we're coming at the distinction between the various thresholds that I showed you earlier on, the 20 to 30, the 50, and the 100,000, versus the 13,000, which is at the bottom of the slide. So NICE, which is the HTA body of England, seems to rest on a societal kind of willingness to pay argument for thresholds, whereas others, like my colleague Carl Claxton from York, they argue that the threshold should be set on an opportunity cost basis. In other words, the amount that we are sacrificing the amount that we are sacrificing of healthcare service we're sacrificing in order to accept and admit a new technology. And that kind of threshold has been worked out iteratively, this 13,000 pounds per quality, through a regression analysis by looking historically at what NICE has approved and by how much. So this is not used, but NHS England, which is the purchaser of medicines, is actually considering this as a basis for discussion or negotiation with manufacturers. So let's talk a little bit about discount rates. So I think from a UK or an English perspective, cost and health effects are discounted at the same rate of 3.5% per year. I think the range is anywhere between, typically in HTA agencies, anything between 3 and 5%. But alternative analysis using rates of 1.5% for both cost and health effects may be presented alongside reference case analysis in specific circumstances, and if specific criteria are met. So we may be applying therefore a 1.5% for costs and health effects if the technology is for people who would otherwise die or have a very severely impaired life. So we want to showcase and effectively accept a threshold which subscribes to that percentage discount rate. The technology that is going to be used is likely to restore them to full or near full health, and the benefits are likely to be sustained over a very long period of time. So in considering, or at least in using this lower discount rate, the appraisal committee takes into account any plausible long-term health benefits in its discussion. So we're looking at the benefits accruing over a long period of time. And that is a testament to, if you will, to a societal perspective. Now, if you, there are other approaches to thresholds, which individual countries have historically used. Countries like the Netherlands and Sweden, and to this paradigm, the UK agencies like NICE and SMC also adhere to. Remember, the old paradigm in the UK, at least from a NICE perspective, was 20 to 30,000 pounds per quality. I think that was a threshold. And anything beyond that would either be rejected, or there would need to be some kind of social value judgment to be to enable coverage. But countries like Sweden and the Netherlands, and with a new approach, the NICE and SMC are doing exactly the same. We are considering a needs-based threshold. In other words, the higher the unmet medical need, or the higher the severity, the higher the willingness to pay, the potentially acceptable threshold. So, for example, based on that, and for high unmet medical need, the threshold in Sweden approaches 100,000 euros per quality adjusted life year. In circumstances where significant unmet medical need. Obviously, if there's lower unmet medical need, or not as much, then the threshold is adjusted downwards, or at least the willingness to pay is adjusted downwards. So I'm hoping I've given you a little bit of an indication as to what is going on. Now, some countries are using the WHO threshold, which is up to the old WHO threshold used to be up to 3 times GDP, and I think GDP per capita, and I think this is calibrated downwards to about 1.5 to 2 times GDP per capita. The other thing which is important here to mention and relates to decision making is about judgments. And when we come to a decision about coverage, we're making scientific judgments, and that relates to the reliability and the quality of the evidence base, the appropriateness of subgroups, the generalizability issues, whether we capture quality of life adequately, how do we handle uncertainty, and that's a very important factor, and also the issue of social value judgment, so the severity of disease, the inequalities, the end-of-life interventions, and so on and so forth. Now, if we, in passing, move from a cost-effectiveness setting to a comparative clinical benefit assessment setting, and travel to France for a minute, you will also see that the French are considering very actively the so-called social value judgments in their discussions about coverage. So, for instance, in the deliberations about the total benefit, they consider not only clinical efficacy from clinical trials, but they also consider the aim of the drug, whether it is preventive, symptomatic, providing symptomatic relief, or it is curative, the therapeutic strategy with regards to alternatives. In fact, if there are no alternatives, then the decision maker is more willing to accept the impact in terms of public health, but also disease severity. So this kind of deliberation informs reimbursement decisions. Now, if we take it one step further in the French setting, to consider pricing decisions, France works on the basis of a ranking order of drugs. So if you are to achieve the highest possible ranking order for a new medicine, in other words, a breakthrough innovation that has an impact, meaningful and measurable impact on a clinical endpoint, such as mortality, you also have to satisfy the condition that this is in a severe disease setting. So you have a clinical endpoint, and statistically significant, of course, with severe disease. So here's a sort of a testament to the importance of social value judgment, and of course the impact on public health. So the public health implications of introducing a new technology. So you can see that both HTA systems, core HTA systems, the cost effectiveness approach and the comparative clinical benefit approach capture these dimensions of benefit beyond costs and effects, either explicitly through the thresholds or explicitly through the ranking order, as I explained in the case of France. Just a summary of the role of social value judgments. I wanted just to share with you two slides. Here's one from the literature back in 2010. So you can see, for example, all this is public evidence, and we know the decisions that have been meta-analyzed from a NICE and perspective, but also from us at research level. So you can see, for example, some of the criteria beyond the quality threshold. You can see, for instance, pemetrexed with a high cost per colli, but it was covered despite the high and beyond the threshold cost per colli on account of severity, end of life criteria, significant innovation in this particular case, and a disadvantaged population was considered in the subpopulation of patients with a nasty cancer, metastatic mesothelioma, because these people had been exposed to asbestos in their earlier life, and therefore it would be inequitable not to include them for coverage purposes, and therefore not to give them their drug. So you can see some of the criteria that play in this conversation, and of course, HTA systems are characterized by a substantial degree of fairness beyond the methodology that they use. So that has prompted people to say that in a cost-effectiveness setting, the colli is a tool, but not necessarily a rule. And here's another piece of research on using cancer medicines, and shows in a number of jurisdictions for a small number of cancer drugs what is happening in terms of social value judgments. And on the right-hand side, you do see a number of social value judgments. Again, severity, unmet medical need, end-of-life criteria, the burden on family, the impact on society, improvements in quality of life, administration advantage, innovativeness, and so on and so forth. So all of these factors are explicitly recognized, whether you're in Australia, in France, in Sweden, in England, in Scotland, or elsewhere. And it's part of the, if you will, assessment and appraisal process. I just wanted to finish off with a few words on value frameworks, and I'm conscious of time. We're talking about an algorithm here, perhaps that countries are using to cover medications. And I think from this slide, which is also taken from our research, you will probably notice by looking at the color codes across countries and the number of stars that there is significant agreement amongst French, German, Swedes, English, Italians, Dutch, Poles, and Spanish HTA agencies about the use of therapeutic and safety endpoints, whether these are direct or surrogate endpoints or adverse effects, or tolerability, and so on and so forth. But there are other buckets, other clusters of criteria which are considered. So burden of disease criteria in terms of availability and prevalence and severity, innovation and innovativeness, but also socioeconomic criteria. But the way we use these factors, it differs across settings. So I wanted to use maybe 1 or 2 minutes to discuss a little bit how in a particular setting, and the setting is cancer, how the value framework that a particular society has used, has put together, is actually used to make decisions and what links that has for coverage purposes. And of course, I'm talking about the European Society for Medical Oncology, MCBS, which is the magnitude of clinical benefit scale, which basically ranks clinical trials on the basis of whether they're using a clinical endpoint or a surrogate endpoint, the performance of the new technology, the new drug, compared with the old one, the hazard ratio, which is an important factor, and of course statistical significance, but also the absolute effect in terms of survival or in terms of progression-free survival or another indicator. I think if you, and I'll probably skip my next two and focus here, if you look at this graphic here, you will notice that the vast majority, ESMO ranks drugs from 1 through to 5, and 4 and 5 are considered to be high score, therefore a very good drug from that value framework's perspective, and 1 or 2 are sort of a low score, and 3 is a sort of an iffy score, which is really relates to an in-between situation as to whether we might or might not admit into listing. And I've clustered the results here based on a sample of 360 drug indication pairs from oncology into listing with restrictions and rejections. What you will notice is that the vast majority of ESMO MCBS scores 4 and 5 have received a listing, and the vast majority of MCBS scores 1, 2, and 3 have received a rejection. However, there may be listing based on low scores, MCBS. So HTA lists despite ESMO saying that it is not necessarily a good clinical trial, a good drug, in other words. And there may be a rejection based on a high MCBS score. And that tells us a number of things about how evidence is used in different settings. So here's a couple of examples of having negative HTA decisions at a particular point in time, which may be reversed subsequently, with a high MCBS score, and positive HTA decisions with a low MCBS score. And you also see that risk-sharing agreements, for example, on the top left-hand side, play a role in accepting medicines with low MCBS scores. So that gives us, puts into our thinking a different parameter in terms of a financial or an outcomes-based arrangement. The other thing which is important to consider here, and that is shown on the bottom half of the slide, is that other studies beyond the main or the pivotal clinical trials play a role in accepting medicines with low MCBS scores. So if you have the time in your spare time to analyze a little bit some of the evidence here, you will probably see that providing indirect comparisons or other studies beyond the pivotal trial and in combination with a managed entry agreement may actually lead to listing despite a low MCBS score. And finally, the role of uncertainties. And some uncertainties carry more weight than others in obviously influencing the final decisions. For example, in a particular drug, it was rejected due to study design issues. The other thing, of course, is the importance of social value judgment. If you look at the lower half of the slide, you will probably see important considerations. So special HTA-specific criteria like population size, severity, and unmet medical needs. So all of these things have been recorded and raised by the competent authorities in England, in France, in Scotland, and in the Canadian setting. And in some of these cases, coverage may have been given on account of, let's say, end-of-life criteria. So, where does that take us? A number of remarks to finish off. Most technologies receive positive HTA outcomes. Of course, HTA bodies have the opportunity to reject technologies. The time to HTA outcome can be significant. It can be anything from 10 to 25 months, depending on the type of marketing authorization and whether it is a standard versus an accelerated one. So that's an important point to bear in mind. So having something which looks like a parallel review process is critical, so that evidence is considered from a regulatory but also from an HTA perspective. ICERs can be influenced by discounting and time horizons, and I think that's an important factor to consider. The thresholds in the context of cost effectiveness can incorporate contextual considerations known as social value judgments, and these social value judgments have actually been seen to make a difference and acting as decision modifiers. But this is not only the privilege of cost effectiveness models. The clinical benefit assessment model, as I showed you, is doing exactly the same. It incorporates contextual factors explicitly into decision making, and the social value judgments can be important, therefore, decision modifiers. The final thing to bear in mind relates to value frameworks. And value frameworks in their current form and to be used as decision support tools focus mostly on clinical benefit assessment. So the HTA, however, based decision making includes additional factors, as I have strived to show you over the past half hour or so. And with these remarks, I would like to conclude and thank you for your kind attention. I think there may be a few minutes for any questions from the floor, and I will be open to addressing these. Thank you very much indeed for your kind invitation once again.
Yes, absolutely. This was most interesting. So thank you very much for your thoughts. And we do have 3 minutes for questions. So please raise your hand who has the question. If not, I have questions. But please go ahead. Yes.
Hello. Thank you for the presentation. It was really interesting. So a question from Estonian Health Insurance Fund. What are your thoughts on this EU HTA changes that will now come in effect in a few years? Will this help us all to bring the new medicines quicker to our patients? Thank you.
Yeah. My team at the LSE provided the background to and the fuel to the European Commission's request for a draft regulation on HTA cooperation. So I'm one of the believers into the fact that creating a body at the EU level will facilitate access to new therapies, whilst at the same time it will reduce duplication of effort. And I think, the key countries that use or have been using HTA for the past quarter of a century are not going to do things differently. In fact, they will proceed doing things in exactly the same way as they're doing now. But I think from the let's say other member states which have been using HTA sparingly or with some doubt, I think it will provide a general framework based on which to build. And of course, this will be a guidance. The additional contextual considerations will have to be looked at appraisal level, which is the privilege of the competent authority that makes coverage decisions and therefore puts money on the table. So I think, yes, I think it will allow, in principle, based on solid evidence, faster access to medicines, but ultimately the decision will have to be made by the competent authorities at member state level. In some cases, the deliberation may lead to negative outcomes because obviously we use cost effectiveness in a different way. We use clinical benefit assessment in a different way, and of course priorities differ by member state. So I'm hoping that through this way we will reduce duplication of effort and we will streamline the timing for HTA and decision making. But we're not going to eliminate the national decision making processes. In fact, my hope is that we will have them strengthened.
Thank you so much for your thoughts. We are out of time, and we will have some more presentation. Otherwise, we would have used much more time. So thank you very much for your presentation and your thoughts.
My pleasure. If there are questions from the floor that people wanted to ask, please don't hesitate to forward them to me, and I'll try to address them. Thank you.
Well, that is very kind. Thank you so much. And next up, we have the Lithuanian experience. So we have Tomas Las, is the president of the board of the Association of Physician Clinical Pharmacologists, and talking about willingness to pay thresholds.
Yes. Do you have pointer?
I think there was a pointer.
Oh, here. Hi, everyone. Thank you for having me. Yes, so there was a short introduction already to willingness to pay thresholds, and it's only one of the alternatives that we can choose. There is also opportunity thresholds, opportunity cost thresholds, but willingness to pay thresholds were the ones that were introduced in Lithuania. So shortly about me, yeah, so I will start with previously, because I was chief specialist at HTA unit in State Medicines Control Agency in Lithuania, and chief specialist at Pharmaceutical Quality Division at the Health Ministry of Health. So I kind of started working as one of the experts that kind of started all HTA process, the processes that are currently implemented. Sadly, I left those jobs, and now I work as PhD candidate at Utrecht University, and ironically, I'm working on unintended consequences of regulatory procedures in medicines. So although it was introduced that speakers will share good experiences, I think I will have some mistakes that we did in Lithuania that maybe Estonia will be aware and will skip those steps that we didn't, sadly. Health insurance in Lithuania is mandatory, as in most countries, and the principles that I was introduced when I started working on the project is universality, that everyone has to be covered, and solidarity, that everyone pays the same amount even if they're not sick. So I think it's very common ground, and it's also described as human right in European Charter of Fundamental Rights. So we kind of started with these principles. And before that, Lithuanian system had only efficacy and effectiveness. There were some cost calculations, but they were mainly budget impact. There were some cost effectiveness, I would say, origins, but not really. The main decision was reached by assessing clinical trials data and assessing, again, kind of duplicating a bit EMA's job at assessing whether the drug is working and would it work in Lithuanian environment. So there were some considerations about comparators, whether we have any comparators in Lithuania, and if the drug, essentially, like very simplistically, the drug was deemed to be reimbursed if it had additional benefit to the alternative that we are using now. If it was the same, it had to lower the costs of National Health Insurance Fund. So when I started working on the project, our aim was to create this additional step of cost effectiveness. The previous presenter said that we could also take a step forward and start considering social values. But for us, it was already a step forward. And the new system, the project has ended, and the new system started working in 2020, not without setbacks. There was a transition period of more than 6 months. So we kind of created the system. The legislations were there, the ideas were there, how we will use stuff. We had a lot of collaboration with Scottish Medicines Consortium, that was also introduced shortly in previous slides. But it was unsure how fast we will be able to move. Some experts still needed teaching, so there was a transition period. The idea was that we will do everything in old system, in old processes, but we will request pharmaceutical companies to provide data also in a new format. This new format was meant to, as pilot studies, not necessarily to base decisions on, but to train the system and to look how we will be able to do that. In theory, it kind of sounded great when we thought about this. What happened was just before that period, we got all the submissions. So all the submissions, that was, I think, double the number of submissions that we would receive per year. We got, I think, almost 70 submissions in May 2019, just before the legislation started. And during that transition period, we didn't got any new submissions. So the idea was to test the system, how it will work. Sadly, it didn't work as intended. So in December, we got the first 6 submissions, both in old format and in new format, but it was kind of the end of the period. It was not enough for us to test those new submissions and to look how it works. So some details, including willingness to pay threshold, were amended only later. Only we had, when we had some data to base our decisions on. Yeah, so as mentioned, we worked a lot with Scottish Medicines Consortium to implement that. And now, how decisions are made, I think probably everyone is familiar with HTA processes, that we have decision problem, data research. Usually it is whether to reimburse some drug. We have analysis, scientific judgment that was done by me and my team, appraisal and recommendation. Happily, at the end, everyone is happy, the drug is reimbursed, patients are happy because they have new opportunities, pharmaceutical companies are happy because they presented new drug and introduced it to the market, regulators are happy because they bought some new advances in the health of population. I want to highlight that values are really important, and it will come later a bit when I will start talking about willingness to pay threshold, because even though I worked in scientific part, hard mathematics cannot answer all the answers, even if I would like to do that. So first of all, how in cost effectiveness we measure benefit. It was mentioned that QALYs are only one of the options how to measure health. It's quite universal. We kind of think that we can apply to all the medicines, even though we cannot. There are famous examples of contraception, but there are some rare diseases that health benefits are not as straightforward as to translate into QALYs, at least by universal and standardized questionnaires like EQ5D. But this was the chosen one in Lithuanian setting. And cost effectiveness measurements essentially are ICERs that are incremental cost divided by incremental health benefits, so QALYs. And willingness to pay thresholds are essentially thresholds to compare those ICERs. So when we have cost effectiveness plane, usually the dominant drugs raise no questions to us. We know that we have to reimburse those. Dominated drugs are also, we can not bother ourselves with those, but when we have higher cost and improved outcome, that's where we have a problem, because how much can we pay for the benefit, added benefit? So there comes willingness to pay thresholds. And it's usually a value used to represent an estimate of what consumer healthcare might be, and prepared to pay for that health benefit. And it is only one of the options. We practically chose it because it was used by NICE, and NICE has vast body of knowledge that we could have used. And also we worked closely with Scottish Medicines Consortium that also applies this kind of thing. But I would raise two problems here. What does it mean prepare to pay and health benefit? So prepare to pay, if you would ask any individual patient if he is willing for the government to spend treatment costs for him, he would say yes. But as population overall, we kind of don't know the value of health and what we are actually buying, because universality and solidarity principles kind of make that we have to ensure that everyone gets access to medicines, but resources are still limited. So are we willing to pay less? Can we pay more? The problem also arises in the way that willingness to pay thresholds are set for future medicines. So now we know we have budgets, we can divide money into different departments. Maybe there's COVID that disrupts everything, but we kind of know from historical evidence how much patients we will have, how much adverse events we will have, how much different medicines we will have to use. Willingness to pay threshold is set for future medicines. So we kind of have models how to infer what will happen, but it's not necessarily the true. It's, as mentioned in previous slide, it's only estimate what might happen. So the deliberation, how much we can pay, is very vague. We know from ICERs that medicines that have very low costs for one quality are very high value. The medicines that you spend a lot of money to gain one additional quality adjusted life year, is of low value, but it also does not necessarily mean that they are comparable. The drugs for rare diseases, for example, usually have quite low value if we look at this line. And as I mentioned, mathematically, it seems kind of nice, and also it was the question was raised whether if we use this technical efficiency, whether it will be right and whether it will increase fairness. So there was a lot of consideration what threshold Lithuania should choose given the new system. There was also small discussions during the project itself, even before the trial period and when the system was implemented. As you can see, most of the countries have thresholds that are not really associated with their GDP. The threshold that was kind of suggested by World Health Organization in 2009 project, I think. 2015 was 3 times GDP per capita, but we can see that this yellow line is kind of showing the threshold set or threshold suggestion set by World Health Organization, and we can see that only Belgium was above it. Most countries were way lower than 3 GDPs per capita. Also, it depends, obviously, on national system, how they distribute money. So Lithuania kind of thought about this WHO initiative, and the first consideration was just to choose probably 3 times GDP. Since both Scottish Medicines Consortium and NICE at the time used 30,000 euros per quality, we also considered that. There was small deliberation whether to choose set value or tie it to GDP, because as some countries now are facing that GDP is rising every year, now we will have a short economical setback. I hope it will be short. But usually it's rising every year a little bit. So we would kind of expect that since everyone is paying for their health, we should spend a little bit more for innovative new medicines, and maybe we should tie it to this value. The problem in Lithuania still, while project was running, was that these considerations were accessed by the press, and there was a little bit of scandalous situation because some people misconstrued that 30,000 euros per quali means 30,000 euros per person, and there was a lot of backlash from some patient organizations who quickly calculated that their diabetes costs in all the years are above this threshold. So there was a little bit communicational mishap that not everyone understands the terms in the same way, and sometimes you need a bit to lower your language maybe, so everyone would be aboard. And I think in hindsight, I did not realize that. When we were working in the project, it was very technical, mathematical, you can understand formulas, but then you have to present your results publicly, and sometimes it backfires. So to minimize this backlash of miscommunication, there was working group set to determine what should be willingness to pay threshold and how to present it in a better way. And there were physicians there, patient organizations, all the parties involved in health technology assessment, budget impact measurements, and all, obviously, Ministry of Health. And the first question was raised mainly by physicians and patient organizations, what is quality and whether we can compare different qualities for different people. And even though we kind of try to build all the system based on Scottish Medicines Consortium, that cost effectiveness, you base cost per quality, we had to let go of some ideas because quality also has these setbacks, and you cannot assess some conditions with quality. So then there were considerations, should we apply only cost effectiveness, or should we consider special groups like children, end-of-life treatment, unmet medical need, or rare diseases? But then there is a question of solidarity and kind of fairness, because some people, we kind of are willing, usually in all countries, also there is literature on that, are willing to spend more money on children. Also, there are some unmet medical needs that maybe cost per quality would be very high, but how do we calculate it and still remain fair? Because even though the willingness to pay threshold was the one we chose, there is obvious opportunity costs. If we are spending millions of euros to drugs that are not necessarily very effective and in generating new qualities, we are taking that money from somewhere else. And there were a lot of debates in that working group, how to make something fair. Do these criteria, which of these criteria can suddenly change our assessment and diverge more money to some groups? So we kind of decided to look at the Netherlands. The Netherlands have 3 thresholds, and they are based on disease severity. So if disease, disease severity or disease burden is measured by disease-related quality loss divided by remaining quality expectations. So if I would be expected to live 20 more years and I have a disease and I lose 10 years of that, and my projection is that I will live 10 years, then my disease burden would be 50%, 0.5, because I lost half of my expected life. So based on that, it was decided that probably this is a good idea to divide it, because it would kind of capture all these very heavy disease burdens and allocate more money to those people. That usually also would include children, end-of-life treatment, because children with severe diseases also have lower life expectancy. Loss of prospect of life usually increases the disease severity. And we actually copy-pasted the disease severity calculations based on Dutch data. And we also created 3 thresholds, one for a low disease burden, medium disease burden, and large disease burden. As I mentioned before, we kind of had this idea to tie our threshold to GDP and not to some set amount of euros, because hopefully the GDP would rise and then we would be able to allocate more money. As you can see, oh, I didn't put euros, but 1 GDP per capita, at that time it was around 16,000 euros. 3 GDPs were 48,000 euros, and 5 GDPs were over 80,000 euros. So thresholds were kind of similar to the Netherlands, however, the budget of Lithuania is not. So the problem kind of arises from this, that I think our thresholds are quite generous. And then in that working group, there was another consideration, because we also had budget holders in those meetings, and they were a bit scared if the drug is reimbursed with these huge thresholds and accepted, and suddenly National Health Insurance Fund has to fund those drugs. So they will might not achieve and get all that money. So concessions were made on evidence robustness. Yeah. So we had higher willingness to pay thresholds, but similarly, as it is depicted with drugs at NHS, when one comes in, the other has to move out. So it is similar to decisions in working groups, at least from my experience. So the higher willingness to pay thresholds came in, but robustness of evidence went down, because then National Health Insurance Fund was saying that, okay, if we're paying this much money, which is a lot of money, we want evidence to be very robust, and then uncertainty tolerance kind of diminished completely. So then we have a system where we are saying that we can pay a lot of money, but suddenly the files and data is assessed in such a way that it becomes very hard for pharmaceutical rights holder to give us that evidence. Obviously, it's new drugs. We don't know how they will act and work in real-world environments. So this was kind of a trade-off that I think everyone should look out for, and it's not necessarily a good thing. And yeah, I kind of mentioned assessment of uncertainty, that it practically went down. Some of the problems actually arise from burden of disease, because Lithuania does not have measurements how heavy or how severe some diseases are in Lithuanian population. So we're using Dutch data. Dutch people usually live way more than Lithuanians do. So all the calculations are already being kind of skewed to the heavier loss of life, because I forgot to check the latest numbers, but I think the Dutch people on average live almost 10 years longer than Lithuanians do. So then it's kind of, we are adapting these high expectancies of Dutch people. We take into consideration that Lithuanians will live as long as Dutch people do, but then we have these disease burdens that are kind of too heavy and push all the diseases to more severe side, because suddenly we lose life that Lithuanians never had. So this kind of makes uncertainty. Also, in disease burden, we calculate QALYs as well, and Lithuania does not have a data set of Lithuanian QALYs. And we see that from different countries, that the same diseases are assessed, even the same questionnaires have the same answers when you move to that one index of quality of life. So it can vary widely. Also, there was uncertain how different age populations are affected by different diseases. So yeah, so these chargebacks would be to look for. And that brings me to the final questions that essentially mathematics can help us answer a lot of questions, but equity, precedent, values and preferences, and acceptability are entirely consensus-based decisions. All shareholders have to have similar understanding what they want to achieve. I cannot say that we were 100% agreeable on all the principles when we were making and creating this system. That's why it kind of got a bit broken. I know that there are some people from Lithuania here, so the process is essentially stopped, and I think the files are laid by, on average, 500 days to be assessed. So these decisions are really to be considered. And cost effectiveness thresholds, pros and cons, as now literature is usually said, that should never be used as standalone criterion for decision making. Sadly, in Lithuania, when we had these huge thresholds, especially for some drugs that are threatening life and taking a lot of quality adjusted life, it became the main criterion. Instead of some uncertainty managements, we just switched that, oh, we will pay for everything, we will somehow manage to get a lot of money, but then the robustness of evidence was raised to the levels that it is impossible for, usually for pharmaceutical companies or even for a health technology unit to get. And how should willingness to pay values of quality adjusted life years be updated according to whom? So there are a lot of considerations. We heard about social value judgment that should be more open. However, it kind of clashes with transparency. On one hand, usually we want clarity and willingness to pay thresholds, at least in all the working groups that I have participated. It kind of looks very clear what we are paying and why. It's very neat. We have sum of money per quality adjusted life year, but then it loses all these considerations. It loses uncertainty, it loses robustness of evidence. So I think the answer is still to be found somewhere. Maybe Estonia will manage to do this. And yeah, and sometimes you can write a lot of reports about possible pitfalls, and yet not all the parties might listen to it. And it requires really a lot of patience to develop a better system. So thank you for your attention, and I hope you have some questions.
Thank you. Yes, thank you so much. Other questions? I think we have time for one question right now, and Thomas will be also in the panel. Any questions on Lithuanian experiences? Okay, from Lithuania, the question.
Yes, from Lithuania to Lithuania. So thank you, Thomas, for very comprehensive presentation. And I have a question. You mentioned that, yes, this willingness to pay thresholds actually squeezed us into the situation that now the robustness of evidence needs to be, at the highest level. Would you think that actually addressing uncertainty or managing uncertainty, because we understand that it is not possible to minimize the uncertainty, but management of uncertainty, could it be done via outcome-based agreements? Would you see this as some opportunity? And then at the same time, what would be your advice for the Estonian system? Because currently the Estonian system is not connected to GDP, so the thresholds are set back in 2011, I believe, and they have not been changed. So what would be your advice in this respect?
If you can be mindful of this time, that would be also great.
So, sorry, first part of the question was... uncertainty, yes. So I think outcomes-based agreements were also consideration. When these thresholds one threshold became 3 thresholds, and the final one was very high, I would say, given the Lithuania's budget in comparison to the Netherlands, the outcomes-based agreement was as possible solution, how we can achieve this. And then the robustness of evidence kind of rose accordingly, that, we will ask very, very the uncertainty has to be managed really well. If you cannot manage uncertainty, then you will have outcomes-based agreement. However, it doesn't work in Lithuania, according to my knowledge, because that requires data. That requires real-world evidence data. And then there were these considerations, who is handling electronic health records in Lithuania. And it kind of complicates stuff because there are no fast-track procedures, how we can obtain that data quickly. Then it kind of becomes manual job that physicians have to fill additional forms. It's not viable for larger populations. So I think it could be possible. I heard that Estonians have better electronic healthcare record databases, so it might be useful and it might be considered. But as I mentioned, also the system kind of started, and then we still had these loose ties to end. And yeah, I don't think that it works very well in Lithuania. And yeah, and about thresholds, I think it would be better to tie them to GDP, because rising GDP kind of then secures future reimbursements for future generations.
Okay,
Yeah,
thank you
sorry.
so much, Zero. I
Yes.
mean, the timing is just perfect. Thank you. And we will have Thomas later on in the panel as well. But next up, Daniela Pavlich from AstraZeneca, the Baltic manager. So you can take the full view.
Yeah, thank you so much for having me here. It's such a pleasure to be part of this conversation that aims to improve access to innovative medicines. I think I will need this one. Thanks to all presenters, thanks to the audience. I know it's the last presentation, but please bear with me until lunch. So today's presentation actually aims to somehow cover a couple of things. How do we look healthcare from the investment as opposed to cost perspective? What is the current situation with the access to innovation in Estonia, but also surrounding countries? We heard from Tomasz about Lithuania. And then thinking through how can we move things going forward jointly. Ryan Lane showed that photo of puppies. I think that's the way forward. How can we do things together? I am in Estonia less than 1 year. So I'm still learning, but I have been working in different healthcare systems from Central Eastern Europe, then also Nordic, Switzerland, and most recently Poland. So I do have a bit of a view, how does it look like. So talking about healthcare from the investment perspective, sometimes it's very logical, but the concept that if economy will go up, then the health will also improve, it's very well understood. Sometimes we do not pay attention that vice versa is also relevant. And then when you look into the reasoning why, lower disease burden will obviously result into the higher productivity and population participation into the economic growth. And I just want to share with you, I'm trying to understand what is the laser, so fine. If you look on the left-hand side, this is data from McKinsey report where they were looking into the potential GDP opportunity growth if the society will improve health. And for Estonia specifically, which is defined as upper middle income country, potential GDP opportunity growth represents 10% up to 2040 if the health will improve, which means in a simple language, for each $1 invested, you can get back $2 as a possibility of the growth. And then when we look into the next data point, when you look health expenditure per capita and how is this in correlation with DALIs, you can see that obviously, and it again sounds very logical, if health expenditure per capita is higher, then obviously disease burden will go down, which might generate this additional GDP opportunity growth. And then we think where we are. I heard quite a couple of times, Ryan Lane also mentioned Finland, so we like to compare ourselves here in Baltic, in Estonia, with the Nordic countries. And then when you look here, it's obvious that Nordic countries are actually investing more per capita in terms of the health as opposed to us, but then somebody might argue, of course they are much more wealthier. And then we have been looking into the countries who are much closer to us in terms of the GDP, like Czech Republic, like Slovenia, and then you can see when you put in correlation that they still invest more, and this correlation with disease burden showcase a similar trend. And let's not be just on the negative side, what can be better. When you look this particular slide, it's important to recognize the improvement that has been happening over the past decades also in Estonia. And that is driven by the ability of also public stakeholders to distribute limited resources, but still secure innovation. On the other hand, when you look at the data, Estonian people still lose 1/3 of their life due to disease. And then when you again compare with the Nordic countries, what does it mean in percentages? You can see here 32% DALYs for Estonian, which is 10 percentage point more than the Nordic country. And then disclaimer here, because I will just apply simple mathematics. It's not pure cost of Thomas is laughing, but then if you really apply simple mathematics, and if you say it's 32%, and then you think about the average yearly income for 2021, you apply that on the working population, you might come to quite significant amount of euros that are lost on a yearly base. Here we talk about 1 billion euros. Once again, simple mathematics. Let's not go into the details, but this is the range we are talking about. And then the question might be, what are the key drivers? And I think, Thomas, you also had similar slide in your presentation, but I think it was related to the overall global burden. Here we talk about Estonian data. And almost half of all lives lost deriving from cardiovascular and oncological diseases. And that's the fact. And the biggest impact, if the investment will be targeted in those two areas, might be achieved, which doesn't mean obviously that we shouldn't invest in other areas as well. But this is something that could potentially deliver on some growth opportunities when we look from the economical point of view. And because we mentioned oncology a couple of times and the burden in this area, and Christina also asked some questions regarding the cancers, I couldn't resist not to also mention the quote from Professor Maimets from the recent 30th anniversary of Estonian Cancer Society, when he said that in several countries, cancer death already outweighs cardiovascular. And it's great to see that Estonia in this context is leading the way when we think from the early screening initiatives, and the strategic document in regards to the lung cancer was launched. The question now is, how do we translate that really in real life and accelerate not just early screening as such, but also access to innovative medicines? Somebody mentioned if the patients are screened and detected, what is happening next? So this is, in a way, sounds quite simple when we say it. It's nothing new, but it's not that simple and quick to apply certain changes. And you heard a bit about the access to innovative medicines from other countries. Here I just would like to share a couple of data points that will show where we are today in Estonia, in the Baltic countries. And I will also pull out some data from oncology field, because we said this is really one of the two key drivers. And for those colleagues who might not be fully familiar, I will be sharing data from WAIT report, which is awaiting to access innovative therapies, publication in April this year, developed together between FPA and the IQVIA, so quite comprehensive one. And then when you look on this graph, what about Estonian patients? If you look out of 160 medicines that were approved by EMA from 2017 until 2020, 1st of January in Estonia 2022, 41 drug was available for Estonian patients. which is a bit better compared to Latvia and Lithuania. On the other hand, it is below EU average. And then the report as such, and I hope this will work, good. The report as such is also giving a bit of a view, what does it mean in terms of the time to availability. And you can see here, for Estonia, it's almost 600 days, so up to 2 years. But then if we move to oncology, it's a same graph, similar trend. Out of 41 approved medicines, currently 22% are available in Estonia. It's 9 medicines. And again, somewhere after EU average, below EU average, and again, similar trend, a bit better positioned versus our other Baltic neighbors. But then the question is, what about time to availability? And then when you look oncology specifically, time to availability is 960 days. And the question is, could we make those medicines accessible for patients faster, especially thinking about how quickly innovative treatments are coming in, because those patients definitely can't wait. Again, saying easy to say, not easy to be done, but it's great to be part of this discussion to jointly understand what would be the best way forward. And then you heard from Tomasz a little bit about Lithuania, so I will not pause there, but I thought it would be good potentially just to showcase what is the HTA methodology comparison in Baltic countries. It started in 2000 as a joint project, so it's fair to see now where we are across those 3 countries. And then let me maybe focus to acceptable willingness to pay. You heard a lot about this one. It's very familiar concept to everyone. And as you heard, Lithuania already implemented a new system. In Latvia, we see from 2020 clear tied up to GDP here. And in Estonia, a system as such was launched in 2011. And it has been defined with 2 thresholds: end-of-life disease, which represented 40,000 euros, corresponded back then to 3 GDPs, and the chronic disease, which was set up on 20,000 euros. And that made absolute sense, because we talk about 2011, innovative treatment, new treatment lines, new treatment options were available in a later treatment lines, when all other options were exhausted. But the question that potentially we might want to discuss is, is this still up to date, given that we are in 2022? And what are the potential levers that might be exploited in order to move forward and secure faster access to innovation? I will not go into the discount rates. Professor from the UK spoke about this one. But then about the limitations. No system is perfect, and that's quite obvious. Tomasz mentioned about some, let's say, mistakes when implementing changes in Lithuanian systems, and it is absolutely true. I mean, there is a limited administrative capacity, there is a line, it takes time until medicines will come to the market, but the first steps has been made. In Latvia, it is the lowest budget per capita. That's again well known, and there is a similar system of waiting list where at the end of the day, again, waiting time to a reimbursement is quite longer, but the first steps has been made. And then when it comes to the limitations for Estonia, it's obvious, it's not tied to GDP, something that was set up in 2011, currently potentially might not be the best setup. And also, when you look into the chronic disease threshold, potentially clarity as such is not very well defined, so everyone is aware what does it mean and when this particular threshold will be applied. And last thing that might be good to be discussed is the point regarding the healthcare service list update, which doesn't have to do anything with the price, but it's broadly common practice to be updated once per year, which might potentially also influence availability to the medicine. Why, for example, if EMA will approve a product in January, February, we prepare the files, we submit by November, 1 year till review, that's actually two years. So potentially something to be considered is more frequent update. And now I just wanted a little bit based on the data discussed, and I think we have sufficient time for that, to present what might be our vision, which changes might be implemented, not each and every proposal to be implemented immediately, but what is that potentially we might be doing going forward in Estonia, learning also from other healthcare societies, and what we as a pharma industry can do better. Because I think it's what I mentioned at the beginning, a really public-private partnership, and only jointly things can be changed. And then, not to go into the details, we mentioned now how HTA systems look like across the Baltic, and the focus was on Estonia, and based on those limitations mentioned, potentially linking reimbursement threshold to GDP, which was mentioned also by Thomas as well today, thinking about, let's say, renewing of HTA methodology to get a bit more clarity on that chronic threshold, and thinking about potentially updating a hospital service list in a bit more frequent way. What is the best way, and how capacity as well will support that one? Obviously, it's not that clear, but it is something that might be out of the interest. And then I come to, and Ryan Lange mentioned that one, and he said we go towards that, which is a value-based medicine. At the end of the day, we should be thinking about the outcomes. But I strongly believe that here we can do better as well as a pharma industry. When we come and when we propose some innovative value constructs to the payers as well, to find a common ground which will not compromise patient outcomes. And here we can talk about the outcome-based agreements. I said I'm in Estonia less than 1 year, but one of the reasons why I decided to be based here was the fact that when I look in Estonia, I see that digitalization, innovation is in your DNA. Ryan Lange said it's not perfect. I'm not saying it's perfect, but when you compare with the other countries, it's absolutely super advanced. And then being in Estonia with such an infrastructure might be really, a quick win to implement those innovative value strategies, because this is precisely something that could address our common goals, which are patient outcomes at the end of the day. And last but not least, to close on that one, are the private-public partnership. Then thinking through from the beginning how our strategic priorities are aligned in order to provide a transparency but also predictability. Because for those constructs to work, at the end of the day, we also need on both sides to have both transparency and predictability. And to sum up, four messages from my side, definitely. How can we potentially look into the healthcare from GDP opportunity growth? It's an investment that could deliver on economical growth quite quickly. The biggest impact derives, as we said, from cardiovascular and oncology disease, so potentially that might be area where this investment needs to be focused on. And the fact is that access to innovative medicines in Estonia, but also all across Baltic, is being below EU average. And Ryan Lange said, we are not where Nordic is, but we will catch them. And I think that should be absolutely a goal, and the goal that we can deliver on if we jointly work together and use those public-private partnerships as a lever to pave the way towards the brighter, let's say, future and the faster access to innovation. So that would be it. I think, Ella, I'm perfectly on time, so 1 minute. Absolutely. Thank you so much for your attention.
Okay. You are on time, or you are on time to have a question, actually. Yeah. Is there any questions from the audience? If not, as always, I have questions if the others don't, but I will give you the priority. I have a question. Actually, you are now managing 3 countries, and you also have the background of so many other Eastern European countries that you noticed, as well as Switzerland, I think, was on your kind of...
And Sweden.
And Sweden. How do you compare the countries? Is there something that we can learn from the other countries? Just what is the best one? We have 30 seconds, we can discuss in the panel later on as well.
It's not 24 seconds answer, and I would lie if I would say so. But I think, as I said, no system is perfect, and the idea from today was really to take learnings from the UK, how they moved towards something new, what was happening in Lithuania. And I think there are examples in, Professor also shared from Sweden. So if I need to give an answer, this is the perfect system, no, it's not. But in potentially, especially Western countries, those private-public partnerships are a bit more advanced, and outcome-based, let's say, agreement and in general innovative value constructs are something that is a bit more advanced. And this is potentially something we need to look in our context as well.
Okay, thank you so much.
Thank you.
So thank you. Let's give an applause and we can move on. And we will have a panel now. And we have one panelist who has not been on the stage yet. So I will first invite to the panel Kristiina Ojamaa, who is the head of oncology hematology clinic at Tartu University Hospital, which is the view of the doctors and the patients, which is something that we need to discuss now as well. Okay. So, and we see that Rain Laane is back, very efficient with the time, as always. We have health insurance fund view. We have Thomas on the panel to give the Lithuanian and the calculation methods, I guess. And we have Daniela also on the panel from AstraZeneca. So let me join you and let me just open up the discussion. And then we can go forward. And this panel is meant to be interactive. So I will let us make one round of opening kind of thoughts. I will lay out the view of what we will be discussing. And then I would very much welcome any questions from the audience. If there are none, I have a number of them. But let us just use this opportunity for the discussions. So just to open up, I mean, we started with the minister who said that we get the most for our investments into the healthcare budget, which is really great. I mean, we are using funds very efficiently. But then we heard from Panos Kanavos that only perfect use of resources, if we do that, then we risk leaving people behind, the patients behind. So what I would like to suggest for the panel to discuss is how to improve access to innovative treatments. What are the values that we can put into the assessment? We have heard about the willingness to pay thresholds. And we know that we heard from Daniela's presentation that access to innovative medicines is still low in Estonia as compared to EU average. We saw that we had just 41 medicines out of 160, and in oncological even less, and the mean times are very, very long. So I would like to open up the panel and then ask Kristiina as the doctor's representative and then the patients, what are the problems that you see when thinking about access to innovative medicines? And then let's go on forward with the panel. I will kind of phrase the first question for you.
Thank you first that you asked me to discuss here these topics. And we heard a lot about the problems that we have. And as a doctor, we should say that about this ESMO, which is the benefit scale of the new drugs, we don't have even those fourth and fifth grade drugs everyone available here. But if you talk about innovation, I'm an oncologist, so so we have to say that the innovation is something that is new, and the innovation means for a patient better life and longer life today. So everybody wants newer drugs, newer technologies faster to reach them. So we have a lot of problem with new drugs because we don't have, we are a small population. So how other countries actually get new drugs, they get by trials, clinical trials, they get by innovative funds which are close to the hospitals, close to doctors. We don't have those things. We have to be very innovative to find the ways there. So in patient perspective, patients don't have the time to wait 3 years for new drugs. And what is the innovation? So 3 years, is it innovation or is it not an innovation anymore in oncology? This is a question. So in doctor's perspective, we have some possibilities like Gift of Life Fund, for example, which is a very nice charity fund which helps a lot of Estonians actually. But how to get the new innovative treatments for patients is a very long way and is a very hard way actually. And a lot of patients do not get them today actually. Yeah, sorry.
Thomas, maybe moving on to you, I will give the last word, of course, to Rain in this first opening panel. Thomas, what about you? You noticed that in Lithuania there is really this long backlog of submissions, and there are new systems, but it hasn't been really developed. So, do you see or do you hear also this similar kind of thoughts or comments as Christina was saying, or are you hearing what is the kind of a ground level experience?
Yeah, so I think my viewpoint is maybe more from regulatory side and what procedures could do and regulators. So I think there is a need in flexibility. Usually like new innovative medicines involves a lot of investments. They require a lot of investments, and I like that Daniela mentioned that it's not expenditures, it's investments into the future, but it's still the sums of money usually are quite high. And I think when it comes to politics and the decision makers, it looks very risky to move fast with innovative treatments. But I think in order to get a faster access, we need to make procedures a bit more flexible and faster moving, especially when it comes to digital age and outcomes research. We have to somehow streamline, especially in small countries. Estonia has wonderful electronic health records. Lithuania has also one system that encompasses all GP data, hospital data. Many of large European countries that developed electronic record systems don't have that. They have limited, fragmented things. I worked in Italy for a brief moment, so Italy, each region has separate system. So we kind of already have advantage to unify all the data. We just need maybe some faster and more flexible attitude how to deal with this sensitive patient data and implement that in faster decision-making processes.
Daniela, you were talking about outcome-based agreements and then also innovative value strategy for the pharma industry. So maybe you can lay out how pharma industry can be a better kind of partner for the systems. Do you have any more concrete thoughts on that?
I mean, I think it's a fair question because it's easy to stand in front of everyone and say, we need more and we need to be faster in delivering medications to patients. I think it is a common goal, but we can do better. I somehow see, let's say, 3 things I can immediately share. I said already during my speech, when we think about innovative value strategies in a country like Estonia, where, as you said, the infrastructure is really there when you compare to other countries, we could be more proactive also coming to the payers and proposing solutions and the way how this could be tracked and what is the transparency predictability behind. Potentially considering portfolio deals, treatment lines, pricing, and so on. On the other hand, and I think it's also fair to point that out, we might be also faster in terms of the reimbursement submissions since EMA approval. Sometimes, and that's also real life, we are operating with resources that we have in-house, and then we also need to prioritize and think through what are the odds to get the reimbursement and get this medication to the marketplace. But I think all of us as an industry needs to think going forward, and it is a part of the debate as well in European Parliament. We need to be fast and we need to be diligent and submit since the day of approval. And I believe that all pharma companies have this global footprint as well, and the forums like this, bringing best practice, bringing stakeholders from the other countries should be a norm, because this is the way how we share experience and potentially importing some practices that might work and address common challenges for specific healthcare system.
Thank you. And then last but not least, Ryan, sorry, we are putting you in a difficult spot, but I guess you are used to this.
It's to me, one moment.
Because it's like we really appreciate your leadership in being effective. We really appreciate your leadership on prevention, which is really important as well. But at the same time, we see that access to innovative medicines is still low. So are there any strategies or thoughts on how to tackle with this?
Yes, there are. When we take this every year, it increases. When I started 5 years ago, it was 1.3 billion euros. Our budget now, next year, it will be 2.1, massive increase. And when you can share it, you can imagine like a big pancake or pie. And when you divide it by 3 pieces, you make 3 cuts or 4 cuts to get 3 pieces. And one is all the our healthcare system contributors' salary. Let's say very bluntly, this is the salary money which doctors, nurses, daykeepers they are getting. That's a pretty big part, 1/3. Then another 1/3 is our purchasing power, what we are able to buy services. These two are connected to each other, because this is like a joint system. If trade unions are negotiating, let's increase salaries instead of 11%, which we have money in the budget, let's increase 19%. Politically, minister agrees, because rescue guys got 36% salary increase, then most probably they will get this money. And but really to see physical increase, salary increase in the bank account, we need to buy these services. And this is one system. And 1/3 of the total money we can call the medicine cost, or the help with the innovative medicines, basically drugs. So 3 different components. And when I see that everybody are complaining, then I can tell we are doing something right. Because if one could be super happy, then it seems that we were too soft or too kind, or however we say. Coming back to the topic, there is no golden key or some secret recipe, but things where we are strategically moving every day is the same thing. We need to start measuring the results, value-based healthcare. Second one, what I really like, the cooperation together with the pharma companies, if we are doing risk-sharing things. With the rare diseases, we can do it. When there are like medicine for the masses, it's a little bit more difficult to do it. But if we know that there are like 20 patients in Estonia, and if the medicine really works, not every one of them, but some of them or most of them, then yes, let's use it more. First, like example, first 3 months pharma company pays, we see that really it works. Patient is alive, and then we take over. That's one thing. Kristiina, you mentioned the donation funds, Toivo Tänavu, Tartu, Tallinn funds. These are everywhere, and unfortunately we are not yet as high-income country as Germany is. As an example, when EMA approves some new medicine, Germany puts it in the list. And I have had many conversations with my colleagues from Luxembourg, Germany. Just recently had 48 hours together with the 6 CEOs from German Krankenkasses. One changed the name, Gesundheitskasse, by the way. And when I ask, what do you do if you were me or in that position, and they smile and say, we just pay. And then it comes. What we do, we rely on the people donation funds, because that gives us year, sometimes 18 months negotiation time with the pharma companies. There are positive examples, there are less positive examples, and if we hear that in Estonia everything is so slow, then honestly this is half true. I'm not saying that we are super fast. No, we are not. But there is some process which we need to follow. We try to make the process smoother. Who has right to submit this application? We are able to read in English. You don't need to translate. In some countries you need to have everything on the official language. We can manage with some other languages. Our medicine committee, which is the advisory organization for our board, they are doing pretty difficult, tough job. And I have seen several times their recommendation that, dear board, for people in our organization, this medicine is really working, this is helping, but the price is enormously high. And then comes the balance point seeking moment. Whether we will help 20 people, whether we will help 20,000 people, whether we will help one person. And we got, a few years ago, we got articles that we are not doing this and that, and several journalists wrote. We did an exercise that was not too kind from us or too nice from us, because we gathered those 6 or 7 journalists in the same room, and we simplified. We put them, we said, you have 2 million euros, and you have 5 cases, 5 applications on the table, and you need to choose. Mathematically, you could give all money to 1 case, you could give money to 2 cases, maximum you could distribute this 2 million to 3 cases, which means that 2 groups of people or person you should leave without financing. One journalist left the room, 2 were crying, and 2 were able to make some decision. And they said that they are not envying our profession or our job. This is what we are doing every day. And coming back, I think we can make better cooperation with the pharma companies, with doctors, to submit those medicines which are really missing in the market. Because honestly, if there are coming, how many, 113 new medicines in the year, and Germany approves everything, and we are there somewhere in between 13 and 35, depends on the year, then there are coming some medicines which are like substitutes to each other. And then the question is, does Estonia need all the variety and all the substitute? We need one or maybe two which can help our people. Let's try to push these into our price list. And negotiations, sorry, we have to do it. One thing where we are a little bit struggling is to fulfill the confidentiality part with the pharma companies when we negotiate, because if there are public tenders, sometimes it's hard. Sometimes journalists are submitting us teabenõue, what is the information claim, you need to reveal the things. And here you have seen us, we push back as much as we can. Because we know that if we do it, then this business model is over. And this business model is working on behalf of Estonian people. There we are, everybody on the same side or around the circle table. So there are strategical thinking how to do. There are some working errors as always. Then there are some cases which typically a few times a year we need to explain to the society why we are not helping or why we are not able to help. But in terms of communication between different parties there, including doctors, including hospitals, the donation funds, there has been the change in the rhetoric. Earlier it was said, Haigekassa, I like very much when people are saying Haige space Kassa. That's a special meaning in Estonian, sick dash fund, is not able to help. This has changed to the phrase that Tervisekassa is not able yet to help. There is a lot of hope. There is a positive attitude that people, let's help at the moment this particular case because there is solution coming. And at the same time, we know that these particular cases are coming in the future because we are not different from the other countries. And those donation funds, look what has happened in UK. Where some of the funds went bust because they were not able to fulfill all the need. And I am always ready to discuss further, listen all the good ideas, and make together the plan how we can execute in the way that everybody will be alive. And you know the exercise when you have cabbage, rabbit and wolf in the same boat and you need to take them over the river. There is a special order how to do it. Let's figure out how to do it, and we are really open for these ideas. And I am sorry if sometimes some of our colleagues are, what's the right word, stubborn, resistant, not as positive attitude as the rest are. They are doing their own job 35 days minus vacation a year. So, but generally, we are in the same boat and we have one common goal, both starting from the industry with doctors, with payers, even politicians. We are for the people to make their lives better. Thank you.
This is very valuable. I mean, giving those thoughts, also really putting the perspective in it. Do you have questions, or I will actually? Okay, we have we do have one question, because otherwise, one thing that I would be really interesting also, Thomas, is to understand from Lithuanian perspective, because you also had all of those kind of value kind of judgments on the table at some point. But let's first hear Kadri's question.
Thank you very much. First of all, big thanks to organizers. It's really valuable conversation here. And as other presenters were here, I actually ask from you, Rain. We don't, in pharmaceutical companies, we don't compare ourselves to Germany, to Sweden, Finland. We compare ourselves to Latvia, Lithuania, Slovenia, Portugal, with the same GDP countries. So in case of oncology, for example, in Slovenia, 26 products are available, almost same inhabitants, a bit higher GDP. In Estonia, 9, according to this survey. But what the previous presenters were advising that also in Estonia, this threshold, GDP per capita, the threshold to ICER should be linked with GDP, not in fixed numbers as we have. 40,000 euro per quali for life-end diseases, and this is since 2011. And in oncology is even for adjuvant settings, for early diagnosis, even 20,000. So it's so low. It's even below 1 GDP per inhabitant. What do you think, how we can improve this, seeing the value of the medicines? Because we constantly get this, as you said already, that price is high, but price is high versus this threshold. Our prices are not higher than in Lithuania or Slovenia. So how you think, how we can improve the perception of the value of the medicines in health insurance fund and also in general public? Thank you.
Kadri, thank you for the question, as always. Two ideas or two pieces of feedback. This is the place where you can help us, because in Estonian healthcare, the super important thing is equality, that we should treat everybody equally. If you try to push these limits up or down, because in a real life, some medicines are working better than the others, even if they have the same relatively high price. And if you try to differentiate that one, then typically ends with some legal claim. We need to find out the way how everybody would understand, or majority would understand, what is a system, how we can pay for something a little bit more because they are better, working better, less side effects, etc. So how we can measure the value that people would understand that one. That is one thing where we need to work, because we really try hard there, but obviously that is not enough. That's one side. The other side, 40,000 euros, actually I haven't seen any official document that it has written somewhere. It's kind of social norm, or is that written somewhere?
Yeah, we get...
So 2011, I wasn't in that business, that's why. It's not in a document, it's kind of common understanding.
It's in the documents what we get when we apply to the reimbursement, and then your colleagues are sending to us.
Yeah, okay. So this is kind of de facto standard, not de jure. Okay. I can maybe say one sentence, what I was dealing what day is today? Tuesday, Thursday, Wednesday is today. Yeah, it was Friday and weekend. Lovely phone calls when somebody wants to steal from you 50 million. It increased 100 million. Then it went back minus 100 million and ended up that minus 50 million for us for next year and years after. Financing healthcare, totally. And I know that this is not your worry, or shouldn't be your worry, that because money comes from the wall. That Ministry of Finance usually does forecast with some conservatism, a little bit, 3 years in a row. And then comes the 4th year when the optimism goes super high. You know this cycle. 4th year means that next year are coming elections. And when I look the numbers, which tomorrow, I guess, will be kind of locked down by government, then we are... Let's look at bright side. Ministry of Finance analysts are predicting that economy is booming and we are getting 50 millions more. Typically, I'm an optimistic person, but I'm in the vice versa cycle that when somebody writes you that you should do by 100 million more and you will get 50 million more, and reality, I doubt that one, then this is somehow answer for the request that please increase this, please increase that, do this, and also some agreed things which should happen next year, like the dental care price change, which we have been waiting also some years, are in the big question mark. So let's go back to the point number 1, which I said, let's find a way how we can prove for us, for our organization, for our medicine committee, that the value is there and it's wise to invest people because they give it as a return for us as a society with the things which they are doing, contributing, paying taxes, adding value, and healthcare is investment, not cost. Thanks.
This is very much, I think we are on the same page as you are saying on this. And I think additional healthcare finance is also something that we totally agree in this room. And if you don't have good health, then I mean, what else is important? But somehow this is one of the missions here to kind of raise awareness that we do have a problem. But actually I would like to ask Thomas, because you were also close to this kind of similar situation, and in Lithuania there was, we can see that there is a need for more transparency to rules. So we do not know what the rules are based on at this point. Lithuania was able to make the change in the health technology assessment and willingness to play level. So you must have had similar difficult kind of discussions, and also about how much to bring the social values into the calculations and not just mathematics. So maybe we can hear from you.
Yeah, so in Lithuania, the current system is that we have cost effectiveness measurements. Essentially, all the data assessment is done by Health Technology Assessment Unit and is given to the separate body, which is Reimbursement Committee, that consists from ministry employees, some physicians, patient organization members, and National Health Insurance Fund members. So a health technology assessment unit is the only one that kind of gives all the file but does not have voting rights in that committee. And it was kind of done purposefully because assessment itself and the recommendation based on numbers, I think, is already kind of steering some people. It's kind of anchoring bias that if you have hard numbers, it's easier to make decision, I think. So there were kind of, with all these considerations about social values, and when we were deciding on willingness to pay thresholds, there were considerations what we will do when we see that something is like that the ICER does not show the true story. There is unmet need, there is, I don't know, some additional things that will not show up in quality. So in the current assessments in Lithuania, there are like parts and chapters, including that reimbursement committee can look over and also make a decision different than recommendation. And also we try to involve patients and physicians more. So there are forms that physician organization or even like singular physicians can fill the forms and supply additional information, maybe some data from their practice or I don't know, some additional data that was not supplied by pharmaceutical companies, even though I think almost like the files are very heavy. So usually it contains everything, but also patient organizations can also supply. And when we were setting up the system, everyone kind of said that, oh, patients will always require some drugs. But we sometimes get that I tried this drug out of my own pocket and I prefer that one to this one. So maybe these considerations can also help reimbursement committee to reach the final decision. However, I'm not sure, even though there is a point in legislation that reimbursement committee can make different decision than HD unit recommends, I am not sure if it ever has been done. I think it's just easier also for, if you're in this pressure position where you have to make a decision, it's sometimes easier to just stick with someone else's decision. So I think it still needs some improvement and work, but it's also very difficult to decide which social things can play a role.
Thank you. And now I think that so many calls have been kind of raised that we can only do better things in collaboration, in cooperation. So maybe we can next focus more on what can be done in cooperation. You have, but Rain, before, you have a comment before?
I wanted to have two comments. First, it seems that it's time to ask some visit to Vilnius. We need to find the time and place and people whom we need to come with, because obviously there is something to learn. And typically with this kind of 2 days trip, because Lithuania is a little bit far away, we can maybe find some solutions in the evening while cooperating. But sometimes people are asking from me recommendations for the reading book, and if I may give recommendations, there is a lovely book, some Indian guy, I think Venkatesh is his name, wrote the book One Day as a Gang Leader. In Amazon you can buy it. Read it. And then you understand maybe this way that exactly the cooperation, because if you want some change, then you need to understand why they are not changing. Why can't they make this change? So basically put the other, the opposite party's shoes for 1 day, and then you realize how nice and easy it is. And maybe then we can get some recommendations how to do it.
we will definitely read the book. But actually, we would really want to hear from Christina. And if I can give you one additional question to what you are going to address, is that when we're talking about the collaboration, when is the good time to actually involve experts into the picture, and where you can cooperate? But please go ahead.
My first comment is that as a doctors, we think that reimbursing new treatment, new innovative treatments, we think that we are kind of in a crossroads right now, because we can understand that as a country you have to provide everything for all the people. You have different directions or different thoughts, but we have to treat the person. So the person's needs are different than the whole country's needs. So this is a big gap between it, and it actually takes new thinking how to deal with it, and that gap is going to be bigger and bigger every day. And if the minister also talked about genes and the scientific data in everyday clinical life and vice versa again, so it means more and more personalized medicine. So the gap is going bigger and bigger. So we have to face it somehow. I don't know how exactly, but we have to discuss it. So when to involve experts, I think quite much from the beginning. And today in Estonia, experts are actually applying and make the applications for the new treatments. And if the commission or committees are discussing the need or whatever aspects of the new drug or treatment modalities or technologies, I think the experts should be there always. Even I think that we do have in the committee patients as well, and I think the presence of patients is also very important, because we do it for them.
Absolutely. Maybe first, Daniela, also maybe you can point out to some good kind of examples of potential cooperation, how to kind of do the public-private partnership. What are the opportunities for the collaboration from the business side?
And you asked me, Ella, before as well, what we can, as a pharma industry, do better. And Ryan, you were not in the room, but I was referring to that puppies photo, because it is in a way collaboration. I think that we could, and there is an example, PHSSR, which is public partnership for healthcare resilience and sustainability, that was kicked off together with London School of Economic and World Economic Forum. And it's actually with the open invite to each and every country to join. And what is the value? Somebody might ask, because project was kicked off with 8 pilot countries, including also some countries from Eastern Europe like Poland, but also Germany, UK, and some international markets. And the idea was, as triggered by COVID pandemic, that actually uncovered pitfalls in the system, to understand what are the biggest pitfalls that will prevent us tomorrow to have sustainable and resilient healthcare system. And the pilot has been done on 8 countries, and so what? The question is, a practical tool was developed that will actually serve for other countries to assess whether my strategic policy documents are really addressing the pitfalls and will deliver on value tomorrow. So this is one of the projects. I can talk for hours about this one, but this is one of the things that we can share today, and I trust my colleagues from other companies as well have similar projects, but it really goes beyond the brand, beyond discussion on that particular level, but a bit more how can we also help public stakeholders to deliver on those patient outcomes. You also mentioned this, this is the common goal at the end of the day.
Are there any questions, or otherwise, I would actually use the opportunity to now discuss on how not to use the good crisis that we had, the COVID crisis, because actually this is a place where we can actually kind of take that. And we had a very interesting note also from the Parliament member, EU Parliament member, who said that EU should be also on forefront of health for rare diseases, for instance, because small countries are just not able to deal with that burden. But maybe before we go ahead, does anybody want to bring this another kind of angle? So please go ahead.
Maybe I will have more like clarifying question. This is to Mr. Lane. So you mentioned during your talk that you are ready, or actually you are already having outcome-based agreements, like companies supplying drug for 3 months and then you are taking over. But at the same time, you also mentioned that more complex schemes, if I understood correctly, are possible only when patient number is limited. So could you elaborate a little bit on that? Do you have any limitations? For example, if we would like to propose some outcome-based agreement where we know that the outcomes should be tracked individually and at different, let's say, hospitals. Let's take oncology and let's take 500 patients. Would you think it would be feasible in Estonia, or how it would be? Just practical question.
Yes, thank you for the practical question. I think it would, because the logic is, I would say it like very simplified way. There is the good pharma company with the good medicine. Less side effects and really effective medicine. We know that for some people it works better, for some people it doesn't. That depends on our genes and physical conditions, etc. And typically we are talking about pretty high price, thousands, tens of thousands of euros per person treatment part. There is a patient, or 500 patients, let's say, and they would need it. And there is a payer who represents the common health money. The working solution can be in the way that we know approximately how many people would need this treatment. Doesn't matter is it 1, 500 or 5,000, but we need to make right calculation. And then we need to do the mathematics and probability. Because we need to forecast in the end of the day that how are we able to finance it. With 5 or 20 patients, it's easier. With 500, we really need to do we need to be sure that these are 500. And why I'm talking this is because I think 7 years ago, when hepatitis C medicine came in the market, then my predecessor did the right decision to allow this medicine in the market. And we ended up as a fund minus 30 million euros loss this year. And the miscalculation was because we knew how many patients are per year, but there was just 10 years uncured patients. And the moment we put it in the list, in our price list, all these 10-year accumulated patients ran in the pharmacy, got the medicine, they became healthy or healthier, they got relief. And that was the right thing to do. But in the end line was minus 30 million. And here I am. Maybe if there wasn't minus 30 million, he could continue. So there is the finance logic behind that we need to know and fit into the budget, at the same time helping those patients. We are willing to pay for those patients whom this drug really works. And if it doesn't, sorry friends in pharma, that is your cost. And then it's doable.
Thank you. Another question? Or comment? Comments are also welcome.
A long queue in our office pretty soon.
Thank you very much. My name is Iga Viigimaa. I come from North Estonia Medical Center, and I'm a hematologist, and I'm very much aware of this risk-sharing program because we have some of them, but we have very few patients. But this comes to the topic of data protection and about the awareness of how many patients of this criteria. This is almost impossible to find out. I have spent several evenings to find how many could be their patients who need this kind of treatment, to give more exact data to the pharmacy company and to healthcare. So this is a hard task. How can we improve this to get better information?
Thank you. This is, again, my lovely topic about DPA, Data Protection Agency, and in a society, after all, people are really in favor, let's give information unless this consists themselves. They are really, they understand that, yes, giving this information and counting all the people who have this rare disease or the same concern, and then we can find this solution. In reality, you said rightly, it's nearly impossible, which means it's not easy. But when I love movie Shrek, there is nicely said, when there is a will, there is a way. And we just need to find a way and then do it as good as we can. And I can also admit that we have been taking and we are ready to take the calculated risk. We know that whatever we think, there is always some deviation. But as I said, please, let's do not make minus 30 million. Let's stay in one-digit number.
Yeah. Well, let's still use this opportunity to think about now maybe the last word for each of in the panel to just think about whether there are any good chances from the COVID pandemic. The health in general, it was acknowledged that is something that we need all of it. So there is a health crisis. And in those times, it is easier to raise awareness of the kind of long-term unsustainability of the system and the need to improve. So let us hear your thoughts, what we can take out of the crisis and how to raise awareness. Maybe Christina.
For cancer patients, COVID crisis affected more the diagnostic area, so people couldn't get the diagnostics on time that they needed, and we can. It's quite subjective opinion right now. It's no doubt data yet in Estonia, but in other parts of the world we have the data that we see more and more and diagnose more advanced cancers due to that because we didn't detect cancer on time. What we really did, we tried to maintain all the cancer treatments as much as we could, and I think all the hospitals in Estonia actually managed to do it. So no big interruptions there weren't, except if the departments were closed due to COVID itself. So what we need actually for cancer patients, we have a very good Estonian cancer plan, which need to start. I mean, it needs a background of financing, so we could start it, and then there's a lot of topics about availability of treatments, the needs by medical staff, and how patients get the treatment. It should be. We already doing it. It's we see that if a patient do not have to travel a lot, so they can get the treatments closer to home. So it helps. It helps more cancer patients than we can imagine, I think. Cancer patient pathways, again, if we had this stroke pathway, we were actually here. So cancer patient pathway is there to be established. Cancer centers actually dealing with it. That the treatment is not the only part of the pathway. The pathway starts from the suspicion of cancer from family doctor. How to do it quickly. I know that in Latvia there are green corridors and yellow corridors, and how they get very fast to the diagnostics and to specialists. We know that our waiting times from family doctor to specialist to cancer centers, cancer specialists, they are very, very long, too long. And it's all the cancer plan, and we also have to consider what we do if cancer treatment don't help anymore. How we treat our patients then, what we offer, what are the options there. It's very important for our everyday life. And what is going in general here, we're talking about the Estonian Cancer Plan. We have, as I said before, we have European Cancer Mission, and it's more exact. And there are a lot of topics about the data exchange, how we should gather our data, or how we manage our ITs, or how we get the data, how we put the data in the system already. How it means that how we put the data in the system, we get the same data. So we have to put it in the system the right way. This is right now the topics we are dealing a lot. So about the treatments, we hope that the thinking is changing. That we really need going the way that we need that we treat the patients, the one patient. So we have to find the right options for this certain patient. We understand that we have to help a lot of patients as well. So we have to find the way for both of them.
Okay, right.
Three sentences. COVID. Patient or people should give the analysis close to their home. And Christina mentioned that also treatment, good examples, Saaremaa and Pärnu and Jõhvi, Narva. People, they don't need to drive to Tallinn or Tartu anymore. Second one, long distance appointment or with the video appointments. Some of them are really working very well. Some doctors, the moment they return to the hospital, they forgot that this good option was available for the patient. And the third one, COVID crisis showed us how quickly can change people mental health, turn bad. And this is where we should put focus. This is also the noticing that if your colleague is having some difficult time, employers can offer also some mental health help, paying some services, etc. That this is serious thing. Mental health, keeping mental health balance. That's what COVID showed us. Thanks.
Okay, Thomas?
Yeah, I think COVID taught us that observational studies and data from databases can be very valuable. Currently, if you go to PubMed and search for COVID-19, you get almost 3 times results as you would have for malaria. So, mainly because of observational research and data that we can collect from routinely collected data in electronic health records. And I think yeah, it was mentioned that Baltic countries are not Germany that could like just give money and finance everything, but we have these advantages of really tiny, tightly collected data that we just need to allow somehow. And also like data protection agencies, very in Europe. So I think there are a lot of potential to collaborate with people responsible for that data protection to make smoother communication and access to that data.
Daniela?
Yeah, what to mention after colleagues who mentioned the majority of the things, but I would say at least the healthcare system, because this was one of the biggest issues during the time of the COVID, early screening, access to medicines as a one part, but then also what Ryan mentioned, you know, utilizing on some good things that emerged from COVID, like those online visits and utilizing digitalization in order to release the system. And last but not least, what COVID taught us that the system is not set up in a way to withstand future shocks, so we jointly need to work together in order to address this one. So again, public-private partnership with the common goal to help patients.
Okay, thank you so much. I mean, thank you all the speakers, the panelists, all those who stayed in the room to hear all the participants. We have really had excellent speakers. We have had experiences from Lithuania, from UK. We understand that healthcare financing sustainability is a common question. Access to innovation is a common question. It's all about collaboration, how to get there. And actually, really, we would like to thank both the Minister and Rain-Laane, you, for your leadership. We really appreciate the value-based approaches and the understanding. It is really, we also very much appreciate that you understand that there is room for improvement, which means that there is room for collaboration between us all, because it is really the happiness index and the improvement in GDP that we would want to have with really healthy people and no problems and no worries. So AmCham Healthcare Committee is really looking forward to continuing these discussions, this collaboration, and hopefully this will actually result in better access to innovation, also better health for all of us. And then last but not least, actually, we have really wonderful sponsors for this event. We couldn't have done it without them. We will have also lunch, which will be served just afterwards. So please, let us thank all the event sponsors who are AstraZeneca, Pfizer, Janssen, Sorainen, and Roche. So let me just thank everybody here.
to say nothing, you don't have to say you're mine.